Himanshu?
Yes, Madhavan sir, vanakkam.
Yes, sir.
Give the countdown.
Okay,
Hello,
sir.
Revati. Revati, good evening.
Good evening, sir. Good evening. But you look dull today. I don't know.
Who?
You.
I'm not keeping well.
Yeah.
Yeah, I'm not keeping well. For past almost 10 days, I'm not well. So,
So,
today
sir,
I got
it's,
the RT-PCR done. So, and Sujata's dad is also very sick.
Oh.
And, yeah.
Mohan, sir, sorry for the interruption. So it's 3, 2, 1. We are live to the audience. We can start this meeting. Over to you, sir.
Okay. Good evening, friends. On behalf of the Tamil Nadu Ophthalmic Association, as the president of the TNOA, I have great pleasure in welcoming you all for this 13th TNOA ARC PG Catalyst Masterclass. As you all know, the theme for this year, TNOA, since I took over as a president in September 2021, is Tamil Nadu Smiling and TNOA Shining. And we've been doing exactly that for the past 10 months. A flurry of activities in the academic front, in the webinars, a huge number of webinars which has benefited a huge number of people. And in fact, I would say that we have crossed more than 25,000 people watching this TNOA ARC PG Masterclass till now, which is, I think, a record of sorts. And mainly because of the quality of the speakers we've been having, the quality of the master classes we've been having, and every subspecialty ophthalmology, starting from optics and refraction to cornea, oculoplasty, glaucoma, pediatric ophthalmology, cataract, retina, medical retina, surgical retina, and refractive, everything has been covered. And today's masterclass, I think we have to give the full credit to Dr. Radhika Natarajan of Shankar Netralia, who's been instrumental, who's been the pivot around this masterclass, and she's a main person in organizing this on corneal infections and inflammation, which is a very, very important topic and very important for all of us, not only for the residents and the postgraduates, but also the practicing ophthalmologists to differentiate. And we're going to have a fantastic time in the next 2 hours. Friends, I have to acknowledge the support of Milmet. The Milmet people have been supporting this masterclass right from the beginning. And as you all know, that Milmet is really a proactive company, part of the Sun Pharma group. And they have been always, they never say no to us, especially for the CME programs. And hats off to Raju and the entire team of Milmet for solidly standing behind us, behind the TNOA, to make this masterclass a very, very huge success, a very popular program. As part of this masterclass, in the month of April, we also had what is called Gurukulam TNOA. The Gurukulam TNOA, which is a unique program, on all Sundays of April, we did it. And starting from 8 a.m. in the morning to 1 o'clock, 1:30 in the afternoon, we had about 19 faculty across the country covering 26 different specialties in topics in ophthalmology. And it was very, very useful. And I had a lot of feedback about this Gurukulam, which is a very, very unique program. And we have to give credit to Dr. Chandrasekhar and Dr. V.R. Vijayaragan of Paramathu for organizing this Gurukulam, which is a huge success. Apart from this, TNOA has also been organizing several other programs. As you all know, the Walk the Talk series is something which has become very popular with the luminaries of TNOA. And a couple of weeks back, we had the Walk the Talk series with whom did you have?
Premraj, sir.
With Premraj. With Premraj, yes, about a week back, we had the Walk the Talk series with Premraj, which is again a very, very motivating and inspiring for all of us to hear his journey, success journey, and how he took a single practice and single room practice to a corporate practice, which is really truly inspiring and amazing as well. Of course, we have the TNOA Connect series. The TNOA Connect series, which connects all the major institutions, which is conducted on last Sunday of every month. And tomorrow, we have got one more on the small incision cataract surgery in association with Arasan Eye Hospital, Erode, and Paneerselvam is going to be taking care of the entire program. And between 11 a.m. and 1 p.m. So stay tuned in for that also, so that you can hear. It's also a very popular program, which has been done with all the major institutions across Tamil Nadu. And I would say that this TNOA Masterclass, this has been a very, very unique program. And the PG Catalyst program, which we started way back in October with we are Vijayaraghavan and optics and refraction, then Cornea with SKR, and then subsequently the several other programs with several other masters who are able to go into the detail. And each of these master classes, we usually have only 1 or 2 speakers, and we'll go into the depth, which will benefit not only the practicing ophthalmology, but also the residents and the postgraduates across the country as well. We've been having a very huge response. In fact, Radhika and Lakshmi Meena were talking in the beginning. I was hearing, because I couldn't log in at that time, hearing that they were talking that how many people will attend. A huge number of people will attend this. Normally on the YouTube and the Facebook of the TNOA. And subsequently, normally an average attendance for a master class is anywhere between 1,000 and 1,500 to 2,000. And subsequently, many people also log on to YouTube and Facebook and get benefited by this master class. With these few words, I hand over this thing to Dr. Ramakrishnan, President-elect, who has been really a source of inspiration for all of us. As you know, Dr. Ramakrishnan is the chief of the Aravind Eye Hospital, Tirunelveli, and he's going to take over as the president from me in a COI conference in first week of August. Over to Dr. Ramakrishnan to say a few words.
Thank you, Dr. Mohan Rajan, the president, respected president, and dear panelists and faculty and moderator of the session. A warm good evening to all of you. First of all, I have to thank and congratulate our president, Dr. Mohan Rajan, for having done wonderful work in the last 11 months in the field of ophthalmology in various formats, like what he has mentioned. There were so many things. In that, this is one of the very popular program, it's a PG master class, which is very much useful for the postgraduates. This very topic is discussed in detail. So in this program, I'm very happy that we have a wonderful faculty and panel members from leading institution of Tamil Nadu, and who have a lot of experience in the corneal diseases, and they have done original work in corneal disease and other published so many papers. And also the moderator of the session, Dr. Rajesh, has done a wonderful work on this, and I am really happy and eagerly waiting to listen to all the talk by the leading people of this session. Thank you very much. All the best.
Thank you, Dr. Ramakrishnan, sir. Your very presence itself inspires us. And I'm sure the next year is going to be even better. And Dr. Madhavan, our dynamic secretary, who would be doing a wonderful job as a secretary of the TNOA for the past almost 4 years now. Over to Dr. Madhavan.
Thank you, dear President. Dear President, Dr. Mohan, our President, RK sir, ARC Chairman, Professor Dr. Rajsekar, the panelists, speakers, and moderators, and of course, all the members who have tuned in to Facebook and YouTube for this wonderful ARC PG Catalyst program. As I was saying, for the past 11 months, the academic activity of TNOA has been going on in a clinical precision, so very well planned and executed by our president since he took over in September 2021. And August 2022, we are going to have our COI 2022 at Pisa Hall, Coimbatore, and we eagerly look forward to all the delegates for the first COVID-free, hopefully, and free conference since the past 2 years. And I request all members to do join us at the conference and make it a successful one. This year, as our president was telling, we have been the helm of activity for the past 4 years. And so this is the year for the elections. And historically, we have planned for an online elections. And I request all our members to kindly update the records of their cell number and email so that we could have a wonderful, comfortable elections ahead. This PG Masterclass has been the most sought after program thanks to the dynamism of our president and the energetic ARC chairman, Dr. Rajsekhar. So we look forward to a wonderful 2 hours of intense deliberations. Thank you. Thank you for the opportunity.
Thank you. Thank you, Dr. Madhavan, and thanks of being with us always throughout and backing the, it's not possible without the support of all the office bearers. And I'll be failing in my duty if I don't mention the role played by our chairman ARC, Professor Rajsekhar. Dr. Rajsekhar has been the nucleus as far as the master classes are concerned. He's been moderating the sessions and so beautifully. The questions he puts forward is really fantastic for all the speakers and the panelists. And Dr. Rajsekhar has been, in fact, I would say, without Dr. Rajsekhar, this masterclass wouldn't have happened at all. And over to Dr. Rajsekhar and Dr. Radhika, the co-moderator, and Dr. Rajsekhar to take this webinar forward.
Yeah. Vanakkam to all. A few words before we give the podium to Radhika, because what a journey it had been. Respected President, President-elect Sir, Secretary, and all the guest panelists and speakers of the day. This had been a wonderful journey. In fact, the only thing ARC Masterclass, the brand, is vying for is what is better, whether the topics are better or the teachers are better. That is the level which we have been keeping till date. Now, the favorite and the most relaxing moment for me is like somebody suddenly sees the clippings, our recordings on YouTube, and just puts a word saying that it had been wonderful. And that single message brightens up the day for me nowadays. And I also urge all our speakers to go into this Tnoa ASC Masterclass recordings, which are available on the Facebook and also on YouTube. You can have a look, and most of the classes have been stupendous and stellar. Today, the layout, I should thank Dr. Radhika Natarajan, because the layout is so very wonderful. The moment the Tnoa ARC Masterclass flyer goes out, our postgraduate community, the young learners, students, and young ophthalmologists, take it up very fast. And suddenly the word spreads like fire, and people tend to flew into this class. And certain times, if they cannot do it into this particular session, they can as well see the recordings. They are there on the net for always. So from that end, the layout which Dr. Radhika has created for today, bacterial keratitis, fungal keratitis, and peripheral ulcerative keratitis, I think that sums up everything. In fact, a student sits and listens to this, I'm sure he can know what he will try to read. Know from our esteemed, and my role today is, which we have, because the chat box is in, I will be helping out Radhe steer the discussion and steer the panel. Harsh. Go to Radhika, please.
Before Radhika starts, I would like to mention the role played by Radhika for, able to hear me?
Yeah, yes, sir. Yeah.
Yeah, Radhika, really kudos to you, hats off to you for organizing this particular beautiful webinar. It is really, in such a short notice, you did it. Thank you very much for that. Looking forward to a great webinar.
Yeah.
Thank you very, very much. I'm really overwhelmed by all these kind words, from you, sir. Thanks to Dr. Rajshekhar also for, setting the trend for this webinar. Even before we start with the first talk, I'll take a minute to thank both TNOA as well as Dr. Mohan Rajan, who has been not only an inspiration, but also a person of stature who's been, in his own words, accessible to all of us for anything academic, that we need at any point of time. TNOA, indeed, under his stewardship, has become bigger and brighter. And I, for one, have really benefited from all the academic activities. Telling my co-panelists how I have created a library of the talks which I relished and I will use. And much later also, these will be, put into perspective and usage. So thank you so much for that, sir. So I would also like to take a minute to thank the speakers and the panelists for today. The speakers are my colleagues from Shankar Nethralaya, Dr. Meena Lakshmipati and Dr. Mamta Agarwal, both of whom are senior consultants, very experienced in infective keratitis as well as inflammatory corneal conditions. And I owe a very big thanks to the panelists, starting with Dr. Revati from Arvind Eye Hospital, who has immense experience in inflammatory and infectious eye diseases. We also have with us Dr. Bhupesh Baga and Dr. Somshila Murthy, both of them from LV Prasad Eye Institute. They also need no introduction. Bhupesh is the keratitis king in this part of the world. So he, should be given singular credit for bringing together people with like interest in infectious keratitis. So under him, we are a group and we have a lot of discussions, part of which will be part of today's meeting. And Dr. Somshila again needs no introduction because she straddles two worlds, one of infection and one of inflammation. So she will be an ideal person to give her experience comments on how to distinguish infectious and inflammatory corneal diseases. We also have with us Dr. Mona, who is also from SN, but from the Calcutta branch. And she also has a wonderful experience both from southern as well as northern India, because she's been located in both branches of SN. So she will be able to give a wider perspective of the geographical distribution and the problems faced in infectious keratitis. And we have on board two young guns, Dr. Preeti and Dr. Sunti, who are both stellar alumni from Shankar Nethralaya. So they have done a lot of work on infections when they were here in Nethralaya, and now they are in their own, institutional practice outside. So they are the best people to kind of judge the differences between the two groups of practice and tell our audience which will fit the bill when. So with that kind of brief introduction, which does no justice to the expertise of our faculty, and again repeating a word of thanks to TNOA and Dr. Mohan Rajan and all those present over here. So let me go ahead and start the first talk. Even before I start, like somebody mentioned, we have intentionally kept the talks low to about 2 or 3 in number, because we want to delve into the details and we want all the panelists to execute ample discussion which will benefit our listeners. We don't want to rush anything and finish, and that's how the program is scheduled. So with that, the first talk is mine. So let me share the screen. Yeah, is my screen visible?
Yes, ma'am, it's visible.
Yes,
Okay.
yes.
Yeah, thank you, admin person. So as you know, I'm Dr. Radhika from Shankar Nethralaya. So in the next quarter hour or so, I'm going to be sharing with you some of the practical aspects that I follow in the management of bacterial corneal infections. So gram-positive infections, as you can see in the picture on the left, usually present with a well-localized grayish kind of infiltrate. And the borders are usually quite distinct, and you have edema which is very local or confined to the infiltrate. So as opposed to this, when you see the picture on the right, Gram-negative organisms usually set up a very suppurative and angry-looking infection. There are lots and lots of exudates which are adherent to the back of the ulcer on the endothelium, and the ulcer itself presents with infiltrates which span across the stroma from front to behind, and generally the infiltrate is more fussy and less defined, and the entire cornea is steamy, and quite often gram-negative infections usually progress leading to corneal melts. So if you see something like the picture on the left, you may think of a gram-positive infection, whereas when you see something like the picture on the right, gram-negative or pseudomonial variety infections are the ones which should come first to your mind. The SCUT trial is the largest repository we have on the subject till date, and the distribution of organisms shown by the SCUT trial was more than half the bacterial infections in the trial were caused by strep pneumoniae, and the gram-negative infections that were caused were because of Pseudomonas. But the SCUT trial also surprisingly had a large inclusion of Nocardia species, which is a little bit rare kind of infection. So what have we seen in Shankarnetralia? Over the last 5 to 7 years, we have also seen staph and strepto predominate in the gram-positive segment. We've also seen a lot of commensals. The diphtheroids are causing more and more infection. And in the gram-negative segment, just like the SCUT trial, we've also seen that Pseudomonas predominates the scene. So of that list, these are the terrible three. The first picture, you can see a pneumococcal infection. Sometimes it can be associated with infection of the lacrimal sac. The characteristic feature of a typical pneumococcal infection is that the ulcer snakes through the cornea, as you can see in the picture, destroying everything in its wake. So it causes relentless marching and necrosis of the corneal stroma. Below, you can see the same Pseudomonas infection that I showed you in the first slide with the large ring ulcer and the infiltrates. But the thing with Pseudomonas is, even though it looks so angry looking, some of the strains of Pseudomonas, or rather many of the strains of Pseudomonas, are still susceptible to the age-old antibiotic, which is gentamicin. So when the susceptible strains are exposed to gentamicin, which we will be discussing in the treatment segment later, it can produce a dramatic response. This ulcer, when I started 45 gentamicin, it literally faded on the face of gentamicin. And you can see that over a period of time, with very careful watch and compliance from the patient, the ulcer has scarred beautifully, as you can see in the picture where the arrow is pointing. And the third virulent organism, which is gonococcus, causing gonococcal keratitis, used to be a bugbear in the past. But since it is mostly a birth canal infection, now with improved obstetric hygiene and practices, we seldom see this infection. Treatment used to be with penicillin, and which was even before my time as a cornea fellow. These infections have become reasonably obsolete now. So these are some unusual infections. In the first slide, you can see nocardia keratitis with the typical pinhead infiltrate. In the second picture in the panel, you can see a deep-seated SICS wound infection caused by atypical mycobacteria. The location kind of gives it away, and because of the same location, these organisms, already they are indolent, difficult to treat. Reach with the medication is also difficult, so they continue to smolder inside the wound. Very difficult to eradicate them, because surgically also, if you want to treat, it's not a simple keratoplasty that will benefit. You need to do a corneoscleral patch graft or something to get rid of the infection. And in the last picture, again, you can see an indolent infection. This is a grafted eye of the corneal graft. Because of the steroids that are being used, you have strep viridans, which has set up an infection. And this again smolders because of steroid use producing crystalline keratopathy. Very difficult to eradicate, because for the graft, you can't stop the steroid. You need a biopsy to find out what organism it is. And therefore, it is also a little difficult to treat and can become recalcitrant. So these are typical textbook presentations that I have showed you till now. But not all ulcers or not all organisms read the textbook and come to us. So quite often, to know what the infection is, we need to resort to corneal scraping. In fact, corneal scraping in corneal ulcers is rather the rule than the exception. There are some points that we can follow, practical pearls, before doing the scraping to enhance our results. It is quite nice if we can give a drug holiday before the scraping. So that way, any organism that has got suppressed or any secondary infection that is cropping up because of antibiotic usage, may not mar the picture. This is easier said than done, because many times the patients have come from far off. They don't have enough time to, spend in our town or stay with us, or many times they want immediate results. So whenever it is feasible, without hampering the clinical progress, monitoring the ulcer closely, it is useful to give a drug holiday of about 48 hours time. So when we have to scrape where the bugs are. If you see the first picture, you can see an ulcer. If you watch closely, there are 3 segments in that ulcer. There is a liquefied necrotic area with pus in the center. The circled area, you can see that the ulcer is already started scarring. You can see scar tissue over there. And where the arrow is pointing, you can see fluffy exudates. So if you scrape the center, you will just get pus. You'll get inflammatory cells. If you scrape the circled area, you will end up with bits of fibrous tissue. So you need to be able to scrape the leading edge of the ulcer to recover as many organisms as possible. Once you've done that, the inoculation has to be done in the respective media and in the form of zigzag streaks or C-streaks. Why do we do this? Because when you make a pattern, then you are optimizing or increasing the surface area whereby more organisms can colonize and grow should the environment be all right. And as important is the scraping, equally important it is to monitor the epithelial defect that we create. If you see the pictures on the right, the top picture shows the epithelial defect against the cobalt blue filter. It's stained with fluorescein. And once you measure this, then subsequently you know whether the epithelium is healing or not. Why is this important? Because in bacterial keratitis, healing of the epithelium is imperative for healing of the disease process itself. So while we're looking at the infiltrates, the symptoms and the other signs, we should also make it a point to measure this after scraping and note down whether it is healing alongside the scarring of the infection. So lab reports must be followed up continuously. There can be a second grower, there can be a third grower, there can be a contaminant. So in all aspects, we need to keep looking at the lab results and not forget about it after 48 hours or 72 hours of reporting. We may need to even interact with the microbiologist to know their perspective. But whatever the lab shows, finally, what is important is the clinical result. Why? Because of 2 reasons. One is patient improvement is the cornerstone of the treatment. Not only that, most of these antibiotic sensitivity results are based on the systemic dosage. They are not tuned or titrated to the ophthalmic levels. So there may be a gap between the lab result and the clinical result, and the latter should always be the guiding force for our treatment. So cephalosporins and fluoroquinolones are the 2 main groups of drugs which come to our mind in the treatment plan of bacterial keratitis. This is a busy slide, but it may be safe to say that earlier generation cephalosporins were more effective against gram-positive organisms, and later generation cephalosporins work broad spectrum. Likewise, among fluoroquinolones, the earlier generation fluoroquinolones work more against gram-negative infections, while the later generation ones are more broad spectrum in action. So that is a simple way of remembering this chart. So we have seen some trends at SN. What have we seen? That, as I mentioned earlier, commensal infection is definitely on the rise. So is resistance to fluoroquinolones. Not surprising considering the frequency with which we use them. And this is not just because of the rampant usage in medical practice or in ophthalmic practice, but the more important danger comes from the usage of these drugs in animal husbandry or veterinary practices and agricultural sciences. So because of random and rampant usage in multiple sciences, fluoroquinolone resistance is definitely on the rise. On the other hand, there is a little good news where we see that gentamicin, which has been kind of phased out of our treatment cards, seems to still work for Pseudomonas. Like I pointed out earlier in a clinical case, some of the strains of Pseudomonas do respond very well to gentamicin, and for me still it is the first to go to medication before I try anything else for pseudomonial ulcers. If we encounter resistance, Now we have the higher concentration levofloxacin. Another reason to try this drug is increasingly I'm finding it difficult to source gentamicin. I don't know if others also face the same problem. So it may be time to test out this higher concentration levofloxacin to see whether it is really as effective against severe pseudomonial infections as it promises to be. So now we have fortified medication on one hand, we have the fluoroquinolones on the other hand. How do we choose? So when you have an ulcer like the one you see in the first picture on top, it's a small ulcer, it's slightly away from the visual axis. This patient is not single-eyed, compliant with medication. There is not a very big epithelial defect. And we found organism on scraping to be gram positive. Then is the time to try monotherapy with fluoroquinolone. This patient was treated with 2-hourly Bigamox. And over a period of 2 weeks, you can see in the photo on the right that the infection has begun to scar down very nicely. And while on the subject of fluoroquinolones, you can see below a typical picture of the rare angular conjunctivitis caused by Moraxella organism. Fluoroquinolones also seem to work effectively against Moraxella. I'm making this point because it's a rare infection. So this snippet of information will serve you well if you keep it in the back of your mind. On the other hand, you see the picture circled below. So there you can see a very thick infiltrate. You may even call it a corneal abscess because you have exudates from the infiltrates from the anterior to the posterior part of the cornea to exudates behind the endothelium. So this is a corneal abscess and this is not going to go away definitely with any monotherapy. So this is a case where we need to scrape and look for organisms and we need to institute combination therapy with fortified medication, keeping the alternative of therapeutic PK in mind if resolution does not happen. So sometimes when we see the antibiogram, the panel shows the resistance to many antibiotics and we get frustrated. So what do? So in those times for gram-negative infections, we can take some, drugs from forgotten times or drugs which are not normally used like imipenem. This is a patient, the panel on the top shows a patient. In the first picture, you can see that the patient has got a ring infiltrate as well as a clump of exudates in the anterior chamber. The patient had a long history. I'm not going to go into the case details now, but did show pseudomonial infection, which was totally resistant to everything. We started the patient on topical imipenem eye drops. Since there was a component of anterior chamber exudation, we also put the patient on systemic imipenem and the patient showed a slow but sure response. And you can see that the infiltrate has almost scarred down nicely and the exudates have shrunk in the picture where the arrow is pointing. Likewise, for gram-positive infection, linezolid is an antibiotic of choice when we encounter resistance. Linezolid shot to fame, thanks to Bhupesh over here, in the treatment of pythium keratitis. But a lesser known fact is that linezolid is also an excellent agent against gram-positive organisms and can be tried for infections which are not going away with cephalosporins. But a word of caution over here that linezolid in the systemic form can cause severe bone marrow suppression. So it is better to use this as topical eye drops only. Sometimes the infection is not so severe as it is stubborn. You can see in the panel below a small ulcer, okay, which you think that even scraping may not be needed, or if you scrape also is going to go away with fortified medication. But we kept on treating and it would scar down a little bit, it would break down or it would come again. And then we tracked it back to staphylococcal infection of the scalp that the boy had, as you can see in the next picture. So only when we co-managed this with the dermatologist did both the infections resolve completely. So when to use steroids for bacterial keratitis? This question has always been lurking around. The SCUT study showed modest effect of using steroids when the disease process is itself under control. So in this panel, the first picture again shows another Pseudomonas infection. You can see the ring infiltrate, but you can also see that the activity is kind of mitigated. This is a patient who has been on antibiotics for a long time and the activity of the ulcer is coming down. In this is the stage where steroids may be of benefit. At one point of time, it used to be taboo to use steroids for pseudomonial ulcer. But what I wish to point out is that If the infection is under control with medication, then addition of steroid under supervision can lead to results what you see in the second and third picture, where the ulcer has scarred down nicely with minimal or no vascularization. So there's also been a little bit of buzz about the use of povidone iodine in the treatment of bacterial keratitis. But I would wish to point out that povidone is a contact sterilizer. It treats where it touches. So while it is probably good for the rare bacterial conjunctivitis, it has zero penetration whatever, and therefore is not to be tried or tested for bacterial infections which have infiltrated into the stroma, and it's also a stinging medication. Doxycycline is a modest antibiotic and a very good anti-inflammatory and can be used as an adjuvant. And many times we see when patients come with prescription from outside, they are on some kind of oral tablets also when they have an infection in the cornea. So when do we give systemic therapy for bacterial keratitis? Only when there is a breakdown of the blood aqueous barrier. When the infection is associated with a postoperative situation like an endophthalmitis, or it is following an injury to the eye where the blood aqueous barrier is broken down, then there may be a role for systemic therapy, like the imipenem patient that I showed. Otherwise, plain and simple bacterial ulcers, the maximum concentration is achieved in the tears by the topical drop, so we do not want to invite any toxicity from systemic treatment. What is the role of cross-linking in treating these infections? PAC-CXL has been shown to have a modest to good role in the treatment of bacterial keratitis, that is the cross-linking that is done for treating the infection. But what else have we seen in Shankar Netralia? All the 4 pictures in this panel have one thing in common, in which the bacterial infection has extended to the limbus. So we all know that however well we size the therapeutic penetrating keratoplastic graft, it is not possible to sterilize the remaining area completely. We may leave behind microscopic or macroscopic infection. So that leads to recurrence sometimes. So what we did is, in TPK-CXL part 1, we used the donor cornea after strengthening it with cross-linking. So we found that cross-linked cornea resists invasion again by these bugs into the graft. So we went ahead and enhanced the study by doing TPK-CXL part 2, where instead of cross-linking the donor cornea, we fixed the donor cornea in the TPK. Then we cross-linked the donor cornea as well as the graft-host junction, taking care to protect the limbus. So TPK-CXL part 1 employs or utilizes the strengthening effect of the cross-linking on the donor cornea and the sterilizing effect of the CXL in the graft-host junction, which may kill any residual bugs. And there is also the possibility of the antimicrobial property of riboflavin working. And we saw that recurrences are far less when this is being used. And we went on to report this also. So you may consider keeping CXL as part of your armamentarium when you proceed to do therapeutic penetrating keratoplasty, at least for bacterial corneal infections. I'm going to close with a couple of interesting case examples. So this is a patient who presented to us with a bacterial corneal ulcer. She had a background history of lichen planus, which is an autoimmune disorder. But the bacterial ulcer was incidental. There was dust or something falling into the eye, and she developed this infection, scraped to show Staphylococcus organisms, and we treated with fortified medications. She was healing beautifully. And then as a healing response came the pannus, as you can see in picture B. So the ulcer, which was scarring till then, once the pannus came, because of the immunity in the blood with the background of lichen planus, at that time, the cornea started to melt, as you can see in picture C. So then we had to actually recess the pannus and continue the medical treatment, and then the ulcer healed completely, as you see in picture D. So when 2 diseases are in play, then you need to understand one's effect with the other before you decide the final treatment, and the outcome may hinge on this. Here again, we had a patient who had injury to the head, and that led to trauma to the trigeminal nerve. So he had persistent epithelial defects because of neurotrophic problem, who should keep coming and going. Anybody who's treated these know how frustrated these are to treat, because it takes much more time to make it heal, and it takes just a couple of days for it to come back again. So you can see the closing PED in picture A. And in one of those episodes, it would come and break down, as you can see in picture B. In one of those episodes, he also came back with an infection in the epithelial defect, as you can see in picture C. So our heart sank. This is, as it is difficult to treat, now we have a second problem in the form of infection. So we scraped it again. This showed strep variant. We treated it with medication. It started to scar down, and scarring brought with it better epithelial adherence. And to our happiness and the patients, once the scar formed, the PED never recurred again at all. Not that I suggest bacterial keratitis as a treatment for persistent epithelial defect, but as I pointed out, when two diseases are at interplay, we need to give due diligence to both. The infective keratitis may not behave in its original manner. So this classic cracked windshield appearance of mycobacterial keratitis is a reminder to us that the glass ceiling is yet to be shattered in the treatment of bacterial keratitis. And there are many studies underway for drug delivery and other research, which the future promises as a solution. So thank you so much for this opportunity, and thanks for allowing my talk. So I'm going to stop sharing now.
Beautiful, beautiful, Radhika. Wonderful. Shall we have the questions and discussion, or shall we have the panel to comment on your talk and then we'll add the question? Or we'll keep everything for the last?
So no, we will definitely ask a few questions to the panelists.
Yeah.
And if anybody wants to add a comment, they can do that also.
Yeah, please.
No, but let me congratulate Radhika. What an awesome talk.
Thank you, sir. Thank you so much for the platform and the opportunity, sir.
You know, what lovely pictures. Okay, each and every picture is a gem, I would say. And it's a spotter. If you see the picture, you will not forget it.
Yeah.
And really, I think it's going to be very useful for the...
Thank you so much. I hope the points get driven home to the students and whoever is listening.
Absolutely. I think we should have a good discussion, Radhika.
Sure, sir.
Yeah. PGs are keyed in certain questions. Shall we start the question so that you can, like, panelists can start it?
Okay. So would you like me to start involving the panel in the interaction at this point?
Yeah. Yes.
Okay, so I'm going to be starting with the senior-most panelist, Dr. Revati. Thank you so much, Dr. Revati, for being over here and sparing your time. When you see bacterial infections, the kind of which I have shown in my talk, what would be your stance on empirical treatment? Because we are looking at an audience who may not have expertise for scraping, or even if they are experts in scraping, they may not have the microbiological facility. So what advice would you give to them about empirical treatment of bacterial corneal ulcers?
Thank you, Radhika. And first, I should congratulate that talk, as the others pointed out. It's not the routine, usual textbook kind of repetition. You take the direction in a very different way, and I think it will be very useful for the students also.
Thank you, ma'am.
And as you pointed out, of course, whenever we talk from the institutes, we always talk about the culture. When the culture comes, we'll do this, we'll do that. And many times the practitioners as well as the others, they may need to start something, and then only they can refer the patient to higher centers, or they can manage them by themselves. So my advice would be learn when you are doing your PG or otherwise also from, as Dr. Mohan Rajan pointed out, like spotters, pictures you have shown, to recognize the pattern, the clinical pattern, at least to differentiate between bacterial, fungal, and among the bacterial, at least to a certain extent, gram-positive, gram-negative, because gram-negative, as you said, good results, but unless you pick it up immediately, it may not be a good result at all. So these things are very important. Once they can recognize a little bit, then they can go ahead and start the empirical treatment. And generally, once they feel that it is bacterial, to go for, unless it is, as you pointed out, a very small infiltrate or something, a quite infiltrate, better to go for a combination therapy. And the easily available drugs they can go. Of course, fluoroquinolones are available as ready-made drops. And among the other things, aminoglycosides are also available as ready-made drops. And otherwise, if they can, and if they are having the background, they can go for cephalosporins. They are wonderful drugs. very less epithelial toxicity also, and easily it can be prepared only like in a, of course, in a clinic or somewhere, they in a sterile area, they have to prepare and give. And also we have to keep in mind whether the patient can keep it, will be able to keep it in a sterile manner in their home also. So the fluoroquinolones definitely I would advise, and in a combination, if necessary, with the aminoglycoside. And as you said, some of the drugs we are simply ignoring. And as gentamicin is your favorite, my other favorite is chloramphenicol. And definitely because this is not being used commonly in general practice, I think many of the ophthalmic organisms, they are quite responsive to chloramphenicol, though it is only a bacteriostatic. Still, it can be effective very well, and in combination with other drugs or in small infections as a monotherapy with a very less corneal toxicity, ocular surface toxicity, it can be used also.
Very, very rightly said, ma'am. In this context, definitely old is gold, because I think the bugs have forgotten about the older medication and their resistance has worn off. So I think it is time to reinvent the wheel by, trying some of these medications. So let me ask the next question to Dr. Bhupesh, if he's on the panel here. Bhupesh, first of all, welcome you to this discussion. Very nice to have you, because you've been the leader of the movement of infective keratitis in this part of the world.
Hi, ma'am. Thanks for the kind invitation.
Bhupesh, welcome, welcome. On behalf
thank
of
you, Doctor. Thank you, sir. Thank you so much. And what a wonderful talk, ma'am, to start.
Thank you so much. Coming from you, that means a lot to me. So I stopped my intro for you in one line because I think it summarizes the whole thing. So Dr. Bhupesh, I also want to ask you, swinging to the other end of the spectrum from, say, chloramphenicol or gentamicin, to the more modern medication, have you had opportunity to use the higher concentration levofloxacin, especially for gram-negative infections? If so, how has your experience been, and what would you tell us as advice regarding that?
Yeah, so I have used in Pseudomonas aeruginosa and in Streptococcus as well. So levofloxacin 1.5% is found to be quite efficient for Pseudomonas aeruginosa. And as a monotherapy, this is actually I really find that this is quite a good therapy. As we know that Pseudomonas, if it started at right time, it works very nicely. So experience of nearly 12 to 13 patients of Pseudomonas with levofloxacin 1.5% alone as a monotherapy actually worked very well.
Right. So that is quite heartening. So do you also use fortified gentamicin in your practice? Because availability is a little short supply now. So what would be your take on using any other antibiotic other than fluoroquinolone for generally bacterial keratitis, specifically gram-negative infections?
Yeah, if they are sensitive, or if we found that they are the gram-negative are susceptible, I prefer to use ciprofloxacin because of definitely is a very nice response and time-tested antibiotic. But if they are found to be resistant, as we get susceptibility in 1 to 2 days, we tend to change accordingly. And my second line is amikacin is always a very good drug, 2.5%. And when we are seeing resistant, then like ceftazidime is also one of the drug which I prefer to use in resistant Pseudomonas, even colistin and imipenem. So these are the groups which are definitely have a very, very good role if you are dealing with worsening Pseudomonas, if you find good antibacterial spectrum. So start with ciprofloxacin as a broader spectrum with a combination of fortified cefazolin in all the patients of bacterial keratitis. When we find gram-negative bacilli or a clinically gram-negative bacilli, ciprofloxacin is most of the time it works so nicely. But if it starts worsening, the second is the amikacin 2.5% or ceftazidime 5%.
Right. I think that is a very nice step ladder that you have said, one which most of us follow over here. And like Revdi ma'am pointed out in between, the patient has to be instructed not only about the compliance, but also of the method of keeping the eye drops. That reconstituted medication cannot be used more than for about 3 days or so, even if some is remaining in the bottle, and maintaining the adequate temperature, labeling, everything is very important. So those are some things that, that come naturally to us, but, we need to actually tell the patient, because the patient may not realize or remember all of this. Any of the other panelists want to chip in with any other points before we go ahead with the next talk on fungal keratitis? Dr. Mona or Dr. Somshila, any pearls of wisdom on bacterial keratitis?
Ma'am, I just want to make one comment here.
Please,
that
Mona.
Nowadays, recent times, one has to be aware about the increased resistance to MRSA and Pseudomonas aeruginosa to fluoroquinolones, because the resistance to fluoroquinolones is increasing. Even in one of the latest articles by Dr. Dua, it has been seen that the region-specific AMR is needed nowadays, because in northern India, there is increased resistance to fluoroquinolones as well as aminoglycosides to Pseudomonas aeruginosa. And in northern India, it has been seen that the resistance is increasing to even gentamicin aminoglycosides, whereas in southern part of the world, they are still sensitive to getafloxacin.
I think you're right. I also mentioned in my talk, Mona, if you don't mind, can you have your video on so that our viewers will know who they are interacting with? So, as I mentioned in my talk, a lot of course, many of us are using it rampantly, which is not a good thing to do, giving preoperative antibiotics, unnecessary post-operative subconjunctival injection, post-operative antibiotics. We think that we are guarding against, a ghost enemy of endophthalmitis, but there are very less and precise protocols that are in place which can prevent endophthalmitis without exposing, the patient or the bugs to any of these medications. But the culprit, a bigger culprit also seems to be the use of these medications in other sciences like agriculture and, veterinary practices. In the same context, I forgot to mention in my talk that there is a lot of MRSA also. Because of hospital-acquired infections, you can have a lot of methicillin-resistant staph aureus, a simple bug that acquires a lot of potency because of the hospital environment. There we have found vancomycin to be the drug of choice. But vancomycin is a brahmastra. So we don't want to use it for every other, gram-positive infection to be able to preserve its use for bigger infections like the MRSA. Dr. Somshila, would you like to make any point?
Most of the points have been very well covered, Radhika. Only thing, and it has also been highlighted, only thing is that the choice of drugs should be based on the most frequently appearing organism in that area, that region, which should be different for North India, maybe for between cases we see in Hyderabad versus those seen in SN or in the Arvind group of hospitals. So they might be different. Second point you have highlighted, but I just like to point out that the resistance is not just because ophthalmologists use the drugs maybe preoperatively or something like that, but it's also because as in general, as a pool of doctors, we use all these medications, and also they're used in agriculture and in animal husbandry. So it's not just us, but everybody put together. So that is increasing the resistance to these simpler agents.
Radhika, if I may add a point.
Yes, ma'am.
One of Lalita's analysis a few years back, I think combined LVP and Arvind, one of the presentations, it was there. In MRSA, when she analyzed, other than the vancomycin, the other drug which actually acts on MRSA was chloramphenicol. Even moxie was even less than that, but chloramphenicol was almost equal to vanco. So that also we can keep in mind in addressing this.
Chloramphenicol is definitely a contender, which can give a helping hand when we are in a little dire and desperate situation. We also always think of it as an olden day medication. It's a very cheap medication, but then we underestimate its potency. And before we move on to the next talk,
I think I just have one point.
Yes, sir.
Yeah. No. We encounter a situation wherein the patient goes from one center to another, and you are the fourth or fifth person you are seeing the patient at that time. and it's a refractory corneal ulcer. It's a very confusing picture. And even if you scrape, you don't get much in that. So what exactly the protocol you will follow?
So, sir, as mentioned in my talk, if it is possible, first we give a drug holiday. The limitation to giving a drug holiday is that the patient is sometimes in a hurry. The patient is desperate for a solution. And also the disease may worsen when you stop the antibiotic. These are the three problems. So if we have a close watch and we give a drug holiday, that gives a washout period for anything that may contaminate or confuse the picture while scraping, first of all. Secondly, this is more applicable for fungal than bacterial. The process of scraping itself should be done in such a manner that you debulk a bit of the infection and you're actually scraping where the bug is. You should not scrape for the sake of scraping. The active part of the infiltrate has to be scraped. And the follow-up of the antibiogram has to be done consistently. Second day you call and check nothing is growing and then we leave it like that, then we are unaware about subsequent results and contaminants and so forth. And last but not the least, if absolutely nothing is coming up, then we can always institute broad spectrum therapy with fortified antibiotics and sometimes employ PCR, which helps us to pinpoint a diagnosis in about 25 to 30% of the cases where the culture is negative. But finally, clinical improvement is the cornerstone. Last but not the least, once it is referred to the expert, corneal biopsy may play a role in very deep-seated infections for us to uncover the organism.
Okay.
The drug holiday not only will help in isolating the organism, and also it can reduce the toxicity. The clinical picture which is due to the drug toxicity will recover, and that will give a better picture also.
How many days?
So,
how many days? 2 days?
48 hours is the recommended period, sir. But with all these ifs and buts in place, that we can watch the patient closely at that time. And like ma'am pointed out, the element of medicamentosa gets eliminated, so the clinical picture also becomes a little clearer.
Rajshekhar, what about the questions from the PGs?
One or two, in fact, 4 or 5 are there, sir. Few points I think they've already touched upon. So I'll ask only the questions which are not touched. Like one question is interesting. Beyond the cycloplegic and this anti-infective drug which you are saying, what else forms the mainstay of treatment prescription? So is lubricants advised? If yes, which one?
So if
this is a question,
Dr. Rajshekhar, you have set the platform for my invitation to the next panelist for her comments, which is we have Drs. Sumati and Dr. Preeti over here, both of whom are, as I mentioned, SN alumni. They're in their own institutional practice now. So how to reduce the inflammation of the bacterial keratitis over and about treating the infection itself, doctor. I'm not going to divulge what she is going to say because it is a new concept. So it's not a presentation, but she's got a couple of pictures of patients in whom she's employed this particular treatment. So over to you, Sumti.
Yeah.
Thank you. Actually, as patients come to our clinic, the primary complaint of them will be like, doctor, I just want to have my pain to go off. So when we are saying into the patients, we have to handle two components, that is infective and as well as the inflammatory component. So infective anyways, like antimicrobial agents would definitely will take care. But inflammatory component is the one which we really have to take care. Like maybe this is the main thing which a patient can get relieved of pain. So I have been using cyclosporin eye drops for the past 1 year. Initially, I was thinking like I was monitored and I was using topical steroids and a milder dose when they are closely when they are able to come back to my follow-up. But based on the results also, I was not very much comfortable and patients were also not coming back effectively. So then I started using cyclosporin eye drops like 0.05%. Initially, I started using in bacterial corneal ulcers. For a few patients, I don't have much of pictures. For initial case, like it was a gram-positive cocci, and first day I started only on an antimicrobial agents, and then by second day, like patient though improved, and the patient was very symptomatic, like with AC reaction and mild trace hyperpion. So I started him on cyclosporin eye drops. 2 days later, when I saw like vision had improved and the infiltrate also started reducing with surrounding inflammatory component of the infiltrate was also reduced. In the final follow-up, we had a small scar, paracentral scar with a BCV of 6.6. And then with a few cases of bacterial corneal ulcers, then recently I started using it in a fungal keratitis. So after giving a dose of intrastomal voriconazole in the day 5, this patient had hypopyon and endoblock, which was not responding to the antimicrobial agent. And then on day 10, I started giving cyclosporine eye drop after clearly explaining the patient that close follow-up is very important. And some patient was very complained. And after starting the cyclosporine eye drop, vision did improve, and patient was relieved of the symptoms, and his complaints for the medication also started increasing. So the left picture is the initial presentation where he had a huge ulcer, deep stromal ulcer with a large endoplaque with hypopyon. And in the final follow-up, we ended up with having a small scar with a deep stromal scarring. And this is a recent picture, like 2 days back. This child presented to me treated from elsewhere. The patient was already on an antifungal medication. The anterior part of the ulcer got healed and it was scarring, but the at the posterior stroma, there was still infiltrate was there. So this patient, along with the antifungal medication, I started on topical medication with cyclosporine, and patient has to come back for this follow-up. So main aim is to reduce the inflammation, and as well as the symptom will become better, and compliance of the patient towards the microbiological agents will increase, and thereby reducing the scarring. So with this, like, I would like to have an opinion from the seniors also. This is my initial thinking about controlling the inflammation differently with cyclosporine. That's it, ma'am.
Yeah, so that is a very interesting thought and concept, that if you have to reduce the inflammation, why not go for, cyclosporine? Before we take other people's comments on this, I think another person who
why not NSAIDs? Can we use NSAIDs?
Not really, sir. I will answer that question for you, that topical NSAIDs have a very limited role in the treatment of any corneal ulcer because of multiple reasons. One is that the NSAID itself is toxic to the healing of the epithelium. And once the patient gets a little relief from the NSAID and continues to use it, then ulceration of the stroma is common even when the patient doesn't have an infection. So I have pictures of patients who have been using topical NSAIDs which have led to stromal melts. So NSAID and epithelial healing don't go hand in hand at all. So I would not recommend topical NSAIDs in the treatment of bacterial keratitis, because the drug has to be used over a prolonged period of time of a few weeks to a month or so.
Yeah.
So okay. Dr. Preeti also has experience with using the same medication. So Dr. Preeti, would you like to add some points to Dr. Sumti's presentation?
Yes, ma'am. So like we see initially...
Would you like to switch on your video? Our viewers would like to know who they are interacting with.
Yes, ma'am.
That's great.
Yes, ma'am.
Yeah.
So me and Sumati, we work together. So I guess most of the cases, she refers to us and we cross-check them. So that case which she mentioned about the endothelial plaque, so that patient was non-resolving for a long time. That's when Sumati came up with the idea of starting on cycloimmune. And we haven't had too much of an experience, ma'am, like the patient pool. Of late only we have started using it. And like she said, we are seeing promising results. And but we make sure the patient is under our watch and we're able to observe if there is an improvement in condition. And we do start topical steroids also in some patients when I see the ulcer is in the healing phase and I want to reduce the amount of scarring, then I would prefer to put them on topical steroids also, ma'am. So cycloimmune is something new which we are trying, ma'am, with promising results. So I think we need a larger population for us to confirm how effective and how long we should be continuing the treatment also, ma'am.
Right. So the thing is that you definitely need more numbers, but we also know that it's not a very harmful medication except for its toxicity. So the question that I have to the both of you is that we know that even in normal corneas, If we use cyclosporin for any other disease, like for example, allergy or a corneal graft, we know that it produces epithelial toxicity. And here we have a disease where the epithelial healing is imperative to the healing of the disease, not like fungal keratitis. In bacterial keratitis and viral keratitis, the epithelium has to heal only in tandem, the infection will heal. So will cyclosporin become a little counterproductive to epithelial healing while it is controlling the inflammation? Have you seen any condition like that?
Ma'am, at least both the cases which, or the 2 or 3 cases which we had, the epithelium was not very bad, ma'am. It was, the surface was pretty good. Those are the cases we chose to put cycloimmune on. Yeah, ma'am. So,
so I think
maybe the patient
need to
selection
have more
was...
patients and a longer follow-up, so that
Yes,
if you
ma'am.
can revert to us, then more of us can start utilizing this as a co-management.
Yes, ma'am.
So,
Surely,
Dr.
ma'am.
Rajshekhar, shall we move to the next talk, because there will be a lot of discussion on that also. So I think we can go ahead with the next talk. Yeah. Okay. So in that case,
One more question, Radhika. Just keep it in your back of mind so that you next time when you start a discussion, start this. I think the next question which we haven't touched is, the student is asking, when will I know that I need to scrape again or start a third antibiotic?
We can answer.
Okay.
That is
We
one
can
of the
answer it
questions.
later.
So yeah, we'll answer that later. Some
Yeah,
of the chat questions,
probably,
or sometimes we can reply in the chat box also. If we don't have time at the end, if we have time, we'll definitely revisit this question. So with that, I would like to introduce Dr. Meena Lakshmipati, Senior Consultant and my very own colleague at Shankar Nethralaya, who's got extensive experience in treating infectious keratitis besides other corneal conditions. She's an expert on treatment of fungal keratitis, and I am as eager as you all are to share her wisdom. Over to you, Meena.
Is my slide visible to all?
Yes, Meena. Yes, Meena.
It's a great honor for Tnoa to have Meena. Thanks, Meena.
Sir, you're always saying this, sir. I hope I do justice for your invitation, and thank you so much, sir.
100% you will do.
And let me tell you, the battle with fungal keratitis never ends. And I hope all of you learn a little. And I'm still in the learning process as much as I read. So it's not moving.
Yeah.
Since this class is meant for postgraduates, general ophthalmologists, and corneal specialists, I apologize to all the senior cornea specialists who already know a lot of basics of fungal keratitis. But just to recapitulate, it's very important for everybody to identify fungal keratitis, how different it is from bacterial keratitis. Feathery margins are the hallmark of fungal keratitis. They can also come as ring infiltrates. They can have satellite lesions. They can present as dry raised plaque or a pigmented plaque or an endothelial plaque. So please be very, very aware about the typical clinical presentations, although there could be very many atypical features. In our own institutes, as we saw the trends of our fungal keratitis between 2014 to 15 and 2019 to 20, our predominant fungal species was Fusarium and Aspergillus. And now we have recent trends of increasing demataceous fungi, although we didn't see this at our institute. A lot of non-sporulating molds, which are nothing but unidentified fungi on culture, have the advantage of being recognized with PCR-based technology. Now, for all the very beginners who are going to see corneal ulcers, this is what you should do. After you see and document and have an idea what it is, you will always subject the patient to microbiological evaluation. This includes scraping for grams and wet mount KOH and plating it on solid media and 2 liquid media. And this is how you should be streaking it on blood agar, as in C-shaped streaks, and do not cut across the agar plate. The materials that are used for plating these media are corneal scrapes, sutures, any biopsy material, and foreign bodies. Now, this is how the microbiologist helps. When you send a clinical smear on a wet mount, you get the cheapest method of diagnosing fungal keratitis, which is 10% KOH wet mount, the sensitivity of which is more than 90%. You will very easily identify long filaments, which are septate, and they are very thin. The next thing which the microbiologist will help you is to see the morphological characteristics of the growth of the blood agar or the sabrodextrose agar, which is the typical agar used for identifying fungal colonies. Furthermore, to speciate this, they will do a lactophenol cotton blue to see the presence of conidia. When the possibility of taking corneal smear directly from scraping from the patient is not available, as Dr. Radhika had already mentioned, we try to do corneal biopsy, which is nothing but trying to raise a flap deeper into the area where the infiltrate is present and trying to either take a tissue specimen or do a scraping. In centers which have the advantage of doing confocal microscopy, which gives a magnification of more than 300% of the specimen, you could identify fungal filaments at various layers. These are very useful for those patients who have very clear anterior stroma, but with a deeper infiltrate, which is not responding to infection therapy. In those centers which have the advantage of having diagnostic methods like molecular techniques, we can subject the smear or the culture for PCR-based diagnostic technique, subjecting the patient for pan-fungal genome, which ideally uses the 18S ribosomal RNA, and also the ITS region, which is very characteristic of identifying fungal genome. But the problem with PCR diagnosis is that they have very various sensitivity and specificity. So for all practical purpose, the gold standard for treatment of fungal keratitis remains identification on culture, and PCR is an adjuvant method of using it to diagnose this condition. PCR has now helped us to identify a lot of new filamentous fungi, some of which I can really not pronounce. They have also helped us to go and look at the susceptibility to antifungal agents and to find out in literature what is the best antifungal agents that you could use for this treatment. So the expert group recommendations, for which I was a part in 2015, highlighted that you need to first encourage a patient not to use home remedies when they have had a red eye. You should ask the patient to stop touching their eye, to avoid touching the eye. Generally, it is recommended not to patch the eye and to use chloramphenicol applicaps when the base of the ulcer is very, very clear. If the patient is not responding, it is very important for the primary ophthalmologist to refer to a secondary care. The expert group recommendations in the part 2 also recommended that when you see a severe corneal ulcer, if there is absence of microbiological setup at your practice, it is important to refer the patient to a higher center. If that's not possible and you see that the patient could have bacterial keratitis, as mentioned by Dr. Radhika, it may be pertinent, it may be necessary to start broad spectrum antibiotic and quickly refer the patient to the higher center. So why is it important that we are studying the medical therapy? It was very interesting that the Cochrane meta-analysis in 2015 reported that with the use of voriconazole, which came about as a rampantly being used drug because of its increased bioavailability, was the most commonly used drug. But remember, in our part of the world, the most common fungi are the filamentous and the yeast are least common. 10 to 25% of our fungal corneal ulcers perforate despite our management, and 60% of our fungal corneal ulcer remain monocularly blind. Natamycin is one of the gold standard antifungal therapy. It's a polyene group of antibiotic which actually causes a disruption in the cell wall. And along with this group in the polyene is also amphotericin. But this is an FDA approved, commercially available. The problem with natamycin, it's a very large molecule, so does not penetrate the cornea very well. And you need to remove the epithelium for it to penetrate into the stroma. It has a wide spectrum of activity. Voriconazole is a newer group of antifungal, which is a triazole group of drug, again FDA approved, has a broad spectrum of anti-fungal activity. It inhibits the 14-alpha sterol dimethylase, that is, it directly inhibits the ergosterol synthesis, which is a cell membrane component. It has a lot of uses because it's available topically, it is used orally. In addition, unlike natamycin, it can be given intrastromally and intracamerally as well. It's important to remember the oral side effects of these drugs, which are hepatotoxicity and other GI contraindications. The mycotic ulcer treatment trial, which was a landmark trial, the MUT-1, was a double-masked multicentral trial, which compared what was necessary for them at that time that they thought was to find out which was more effective. They came out with the results that in over 300 patients that they studied, the 3 months outcome, the natamycin was probably better. And also the patients who received topical natamycin had less chance of perforation. And they also found, since their group of patients had majority fusarium, they fared better with natamycin. So this study was a landmark study in that they questioned the role of monotherapy of voriconazole, which was predominantly being used earlier. So this also in 2015 was published by Sharma et al. They also found that natamycin had a better outcome, especially when fusarium was the etiological agent. The alternate is possible. You always look into the literature that the Arvind group had already found out that iconazole was as effective as natamycin in their randomized control trial. But however, I'm not very aware about its availability. When we looked at the in vitro susceptibility, which was one of the outcomes of the MUT trial, they also looked at why some patients did better and why some did fared worse. So they looked at the MIC levels and they found that the MIC levels of aspergillus and the fusarium differed to natamycin and voriconazole. Wherever it was higher, the patients tend to did worse. And the higher the MIC levels, the patients had a higher chance of perforation. Although this is not very routine to use, to tend to try and find the MIC levels at microbiological setups, it may be a routine care in later when the standard of actually trying to do the MIC levels has become standardized. It is very difficult and it's usually recommended for non-responding cases. So we have two drugs that we have spoken, natamycin and voriconazole, and we always see a combination of this. So this was an interesting study. They found whether they could be used commonly together, especially for this filamentous fungi, both the Demetaceous and hyaline, and also for the Candida species. They find that although there was no antagonism, that meaning that one did not reduce the effect of the other, there was minimum synergistic effect. So there is no harm in actually using these two drugs together. So this was another study. So instead of voriconazole, with used amphotericin to see if there was any synergism. So again, a good point was there was no antagonism. The possibility that there was less synergism could be explained by that amphotericin and natamycin both possibly are looking at the same site of action. That is why there is no great synergism. When comparing natamycin and voriconazole, especially since I've already told you whether we need to debride these patients, I'd like to highlight that although in clinical practice, some of us would like to debride the patient for better penetration of the drug, this group, which found 4 arms in which they divided 2 groups of drugs with and without debridement, found that those patients who underwent debridement had a worse clinical visual outcome. But maybe in a subset of our own patients as we practice, it may not be that bad as an idea to do debridement, especially if the patient is non-compliant to the medications. Aggressive debridement has also been useful, and I'm not going to go into this study because the previous study has already said that it has not found to be very effective, but in your own setup, you may find some patients responding. We look forward to the aqueous preparation of a natamycin, which is called natazole, which is present as a 1% topical medication as a 0.1% intrastromal use. There is the advantage after topical therapy to try and to inject these drugs into the site of its activity, rather closer to its place where it is very, very active. And this is known as targeted intrastromal therapy. Both voriconazole and amphotericin B have been tried. The general rule is to cause a barrage therapy with the 26-gauge needle around these infiltrate. It's important to establish the diagnosis to know the culture characteristic before you do this, It's done under local anesthesia, under all precautions, and you expect some amount of pain and probably intrastromal hemorrhage at this point. If there is worsening, therapeutic penetrating keratoplasty has to be done. Generally, two times, 3 times these intrastromal injections can be given with a gap of 48 to 72 hours. The adjuvant therapy with intrastromal, the new natazole has already been tried, and a favorable outcome has already been established when compared to intrastromal amphotericin B and voriconazole. However, we need larger groups and more people to actually make sure that these results are valid. But this was interesting to say that none of these patients who had this intrastromal new natazole had any complications, whereas those who received amphotericin and voriconazole had more vascularization. When you see the outcomes of intrastromal voriconazole, I had 2 studies between 2011 and 15. It's seen that 80% seem to do really well with the intrastromal voriconazole. But there could be a problem of intrastromal hemorrhage after the injection. And the outcome with fusarium is not really very great. And they did a randomized control trial where they used the standard regime of natamycin versus the intrastromal form of voriconazole versus the topical form of voriconazole. And they found that those patients who received topical voriconazole fared better than the intrastromal voriconazole. And in fact, in these 20 patients who received intrastromal voriconazole, you'll see the number of perforations were larger. So now we come to an older drug, a polyune drug, which has existed for so long, especially now you would have heard this term during the pandemic, the amphotericin. So amphotericin has probably not been used for long, but do not forget, when nothing is available, you can still make use of this drug in intracameral or intrastromal form. But beware that there could be some reactions, especially for inflammations. The general indications for this are when the etiology is Candida and Aspergillus and Fusarium, not much. And you will do it for those patients which are deep-seated and who present with an endothelial plaque. The dosage is 5 to 10 micrograms per 0.1 ml. We look forward to other new therapies, especially the liposomal amphotericin. We look forward to other methods of instilling these drugs with the help of microneedle. Now coming to oral therapy, you have a whole group of antifungal agents. The azole group of drugs are commonly used, and I have highlighted what is the dosage of these in this slide. In the MUD2 trial, they also wanted to go ahead and try to prove whether oral voriconazole had any superiority over of the placebo when the patient was already on a topical therapy of natamycin. They found that there was no difference in the need for therapeutic penetrating keratoplasty. But they showed that in the subgroup of these patients, those patients who had fusarium in their culture might benefit a little with oral voriconazole. They really advocated to look at the adverse reactions of oral voriconazole, such as cardiac, visual disturbances, gastrointestinal, and it is a photosensitizing agents. In this way, you will have to monitor the patients for the liver enzymes. So they concluded that in 3 months, those patients who received voriconazole and who did not, there was no difference in the rate of epithelialization, their visual acuity, the infiltrate size, and scar. The possible indications in a clinic for use of oral indications when it is deep, when it is bilateral, when there is impending perforations, or when it has become an endophthalmitis. Now, the other group of drugs after which have now, what drug that we have used was against the cell membrane. Cell wall targeting now is the mode which the world is now progressing. These are known as the iconocandins, which are 1 to 3 beta-glucan desynthesis inhibitors. Micafangin and caspofangin are some of the things which I read in literature. I have very little experience. Caspofangin used in refractive case of Candida has been published, and the dosage is being mentioned here. Posaconazole is another newer triazole compound. It has a very broad spectrum antifungal, and it has a very good penetration. I probably would look forward to using this group of drug, looking forward to making sure that the liver enzymes are well controlled. There has been both formulations, both for topical and for oral medications. So the cross-linking, which we are all aware and have done as cornea specialists for keratoconus, releases reactive oxygen species in the presence of UVA and riboflavin. In our early cases, in our own study, we found that in early cases of fungal keratitis, used as an only adjuvant therapy, meaning along with the antifungal therapy, we found some useful outcomes of this cross-linking. But Madhu Udayraju, in his study, in the deeper mycotic study, almost said that it was actually of no use, and there were treatment failures and perforations. The CLARE study, which stands for the cross-linking assisted infection reduction study, which was a randomized controlled trial, had 4 arms. In this, the standard drugs was natamycin and amphotericin, and they were clubbed with cross-linking. What they found was those patients who underwent cross-linking neither had lesser smear or culture positivity, meaning that cross-linking really did not eradicate the organism. And at 3 weeks, the visual acuity was not any greater in those patients who underwent cross-linking. Rose Bengal photodynamic therapy, they replaced the riboflavin with another photosensitizer, riboflavin. It's been introduced by the Bascom Palmer, and its first organism was very effective for fusarium. They subsequently went and did a randomized control trial where the majority of the patients which they used was acanthamoeba. Out of the 6 patients of fungal keratitis, 2 patients did not fare well. 1 patient had corneal edema and 1 patient had perforation. So the Dr. Sharma et al. Have put what they thought could be an algorithm for the treatment of fungal keratitis, starting from the standard regime of natamycin, which I'm reiterating is the first line of therapy. If there is worsening, you can combine with voriconazole. Whenever there is deeper infiltrates, they have advocated the use of intrastromal or intracameral antifungal. And when there is worsening, they have advocated that you should need therapeutic penetrating keratoplasty. Always continue the natamycin and voriconazole if there is a good response. The problem with this algorithm is that now we have more species-specific identified susceptibility data. Whether we could use cross-linking earlier is also questionable. And we also need antifungal susceptibility to help us as we know in antimicrobial therapy for bacterial agents, which agents could be better. So this is a case where we gave antifungal therapy topically, and once there was worsening because of deeper infiltrates, we gave intrastromal voriconazole, and it helped us resolve the case. But this may not be always the case with all your cases, and always keep a close watch. Surgical management may be necessary when there is a perforation in the form of tissue adhesive bandage contact lens, a patch graft, and when necessary, a near total graft change like therapeutic penetrating keratoplasty. This is a case that I would like to highlight. It was a young boy who came with 2 small infiltrates, really rare to see 2 small fungal infiltrates with no previous history of trauma. This patient was treated with a single antifungal agent, natamycin, and for cycloplegic, we use homide. He typically resolved in 2 weeks. His underlying immunological status was normal, and he was not a diabetic. And again, I would like to tell all the youngsters that checking for blood sugars is very, very imperative. This is another patient who came with a deep infiltrates. As we know by the TST protocol, once we start natamycin and there's worsening, we also add voriconazole. We started oral ketoconazole as well. He did well. In the day 7, there was scarring and there was absence of hypopyon. And by day 30, you have an anterior stromal scar. We really, although it was seen to extend out to the limbus, we did not do a therapeutic penetrating keratoplasty because we had a close follow-up and the patient was scarring. Now look at this patient who came with a really small central infiltrate, which looked as if it's going to resolve. And we had a close follow-up, did debridement and added the antifungal agents, both natamycin and voriconazole, and also topical ketoconazole. But in 2 weeks' time, you will see the hypopyon just progressed and there was an extension into the limbus. So this patient was subjected to therapeutic penetrating keratoplasty, and at 1 week, you can see an exudate which is coming as a tongue shape from the angle for which he received intracameral voriconazole. and he typically resolved in 3 weeks. And right now, the graft has failed, but nevertheless, the patient is doing well in the terms of anatomical success. We look at this patient who was a recently known diabetic who developed a central corneal infiltrate without any history of trauma. It was large and it was deeper stromal involving the posterior stroma as well. This patient underwent the routine scraping. We see many septate fungal filaments, and the culture grew within a week's Aspergillus flavus. In the events that we saw, we were hoping that although it started resolving in the corneal part of it, the hyperpion kept increasing. And we had a very close watch of the intraocular pressure, which tends to be very high, but especially when you see that the hyperpion is increasing. So this patient, because he was clinically worsening in the form of being very symptomatic, his diabetes thing was fluctuating and there was increasing in hyperpion, he underwent AC wash with intracameral amphotericin B. In 2 weeks, he did well. The anterior, the corneal infiltrate resolved, the hyperpion was nil at the end of 2 weeks. So to conclude, scraping to see filaments by direct smear is very, very important. The first line of treatment is 5% natamycin. If there is worsening, you may have to add voriconazole eye drops. Culture is very important to see whether it is fusarium or a non-fusarium, because fusarium can do typically worse if you have started the patient with only voriconazole. You need to add an oral agent, especially if it is worsening and deeper stromal or if there is hypopion. You may prefer to do intrastromal if the patient has already been culture proven. There's an anterior to mid-stromal infiltrate, and make sure that there is no thinning, and you may have to repeat it in 48 to 72 hours. So there have been other polymers which have been now tagged to these antifungal agents to allow better bioavailability. Thank you so much. I hope you enjoyed my presentation. I would like to acknowledge the L&T Microbiology for helping me with this presentation. Thank you so much.
Wonderful.
Thanks a lot.
Beautiful.
Thanks a lot.
Wonderful.
Nina, wonderful.
Wonderful.
Amazing.
Can we involve the panel in some discussion? Dr. Mohan Rajan, Dr. Rajshekhar?
Yes.
Yeah, so that was an excellent talk, Meena. You covered end to end almost all that is needed to be known about fungal keratitis and its treatment. Before we start asking the panelists, I have a question for Dr. Meena herself. That you very nicely showed that in certain situations where the infection is deep, intrastromal injection does seem to do the job. You also mentioned that to be able to give this infection, we need a clinical diagnosis first. So many times in fungal keratitis, the picture is very typical. You get feathery infiltrates, you have a patient who's not very symptomatic, diabetic background, satellite lesions. But sometimes these deep infections can be a little bugging. You know, you see a ball sitting over there or an endothelial plaque. With no access, the scraping is not showing or growing anything. So before giving an intrastromal in such cases, how would you demonstrate the organism? Would you do a corneal biopsy or do you have any other ideas about this?
As a routine, unlike for bacterial keratitis where empirical therapy has been advocated, for fungal keratitis, it's very important to actually prove the infection. We need to know whether it is a filamentous or whether it is candida. And to help it penetrate, we need to do debridement. Clinically non-responsive fungal keratitis, as we now know, could also be pythium keratitis. So re-establishing the diagnosis that it is not fungal and it could be the most mimic of fungal keratitis, which is pythium keratitis, right now is the most important thing. So you subject the patient to either a PCR diagnosis or you would like to do zoo-score as per whichever your laboratory is familiar with. I am a big advocate of doing deep corneal biopsy. I'd like to lift a flap. Either I remove a block of the tissue and subject it to histopathology and microbiology, or I would like to take a deeper corneal scraping. There are groups, however, who have also done Desmet's scraping for taking these lesions to subject them to microbiology. before I enter the eye, I would always like to try to explore as much as possible from the corneal approach. Where possible, I would also advocate the use of confocal, which needs a higher expertise. The availability is very, very subjective at this point. Other than biopsy, PCR, subjecting the tissue to PCR and confocal, which would really aid us in ruling out other infective agents, could help us a lot.
Right.
And never start the patient on steroids when you are suspecting that the patient could be fungal keratitis, should be one of the most important thing to be kept in mind.
Right. All points very well taken, Dr. Meena. Even the point about the corneal debridement that you said, even though a couple of studies have shown them, to have equivocal results, even I'm a big advocate of scraping, because A, you don't lose much by doing the scraping. B, there could be multiple benefits. You will get the organism many times in fungal keratitis. You will debulk the infection, especially if it is a plaque, then most of the infection actually goes away when you do the scraping, and you create a channel for the drugs to go inside, because fungal medications are notorious for non-penetration. But one simple word of caution is that we need to pay attention to the deeper stroma while scraping, so that we don't scrape a thin area and have a perforation with aqueous trickling on the slit lamp table. And the biopsy techniques also you have elucidated very nicely. One additional point that I would like to make about that is, the block that we take or the sample that we take, we're all the time thinking of infection. It is good to subject a very small part of the specimen to histopathology as well, so that we know the kind of inflammatory infiltrate, number one. And number two, some bugs have a way of showing up on histopathological stains also. So HPE should also be done, with a very small part of the sample. Now, Meena has set the tone for my next question, which is how to distinguish fungus from pythium. There is no miracle answer to this, but for the uninitiated, it would be a good question to ponder about. And there is no better person to answer this question than Dr. Bhupesh on this panel. So Bhupesh, can you tell our listeners some of the pointers that you may have for them to distinguish the dreaded pythium infection, which is a kind of old kid in a new block, and how they can easily mistake one for the other, and how they should act when they suspect pythium keratitis.
Dr. Radhika, I think again very nice talk, Dr. Meena, and thanks for that. So to differentiate from pythium from fungus, actually starts when you pick up filaments on KOH and on grams, and your fungus ulcer is not responding to your antifungals. That's actually a strong suspicion of that you are dealing with either pythium or pythium or some sort of resistant fungus. Clinically, both can be differentiated by few telltale subtle signs that pythium has. But I think Dr. Meena has not shown that, but I think pythium shows very fine tentacles, which are a little different from the hyphae as we see in fungus. Second is the pinhead lesions, which we see both in fungus and in the pythium, but very fine, and the density of those lesions in the surrounding stroma can be seen only by the sclerotic scatter examination. So those are the two signs. And third is the formation of the gutter around the infiltrate, sort of raised infiltrate with shallow guttering around the infiltrate. So these are a few signs which are marking towards pythium. And also the infiltrate is a little bit of dry looking as a raised. So these are the signs when your fungus ulcer is not responding to routine antifungals of nearly 1.5 weeks or over, and still it is worsening and rapid worsening with plenty of tentacles, more of tentacles rather than infiltrate. Start thinking about this organism. On a KOH, you start seeing the aseptate form of filament, which is different from the fungus in its size, because this is the broader ribbon shaped, which is less as different as from the fungal filaments, and they are aseptate or sparsely septate. So ribbon-like folds, broad aseptate, in KOH and in grams is usually you're dealing with Pythium, and definitely it will culture definitely will confirm it with a zoo spot formation or PCR.
So very nice points, Dr. Bhupesh. And while you're at it, your team has been the first to establish that some response can be obtained to medical therapy. When, earlier when Pythium was seen, it always progressed to therapeutic PK, and that was not even the endpoint. It was notorious for recurrence. But you and your team did establish that there is some hope for medical therapy. So can you enlighten our viewers on that as well?
Yeah, so as we know that there's a lack of ergosterol in the cell wall of Pythium, so antifungals are not going to work, and so we have to deal with that. So we establish based upon in vitro susceptibility that a combination therapy with the linezolid, tetracycline, or erythromycin actually work very well in cases who are coming at as a mild to moderate, or basically till the mid stromal or till the posterior stromal involvement. And they actually, we have found almost 50-55% cases who are actually before to this medical therapy, almost 100% therapy cases were going for therapeutic keratoplasty. Now we can avoid at least in 60% cases of Pythium keratitis with the medical management alone, with the combination of linezolid. Linezolid is we give topical, and it is available as a IV solution, intravenous solution. We need not to dilute it as 0.2% directly, can be used as a topical, and there was no toxicity found. Now we have established in rabbit Pythium model, as well as we have almost 200 odd patients also. We have given published papers also on that. So there's no toxicity of linezolid topical, along with erythromycin, either in form of drops or ointment, can easily be given in this. So this is basically a combination therapy which works. And in deep stromal and in the anterior chamber involved patients, we definitely need to give either oral erythromycin or oral linezolid in forms of tablets. So tablet erythromycin 500 milligram OD or tablet linezolid 600 milligram twice a day, along with topical medications, usually suffice in these cases.
Right, and to watch out for blood counts as well when we use systemic.
So that is very important when you are giving oral linezolid. I do check every week complete blood counts before starting it, and every weekly, and before starting erythromycin as a routine, we definitely do electrocardiogram and rule out any QT interval prolongation, because that definitely can be arrhythmogenic in these cases.
Correct. The cardiac evaluation and monitoring of the blood counts. Thank you so much, Bhupesh. Before we move on to Dr. Rajshekhar, take any of the PG questions, one last question that I have personally for you is that you very rightly mentioned that we encounter two varieties of Pythium keratitis, one in which we see the reticular infiltrates, the tentacles with dot-like satellite lesions, another variety which may coexist or be separate where there is a guttering ulcer. The variety which shows the guttering ulcer, do you believe that there is any immune component to that? In that case, would there be any role for cautious use of steroid in Pythium keratitis, or would it still be a taboo?
No, it's a big no to corticosteroids. It mimics very, very closely to peripheral ulcer keratitis cases, and we have published those papers. There's cases of Pythium keratitis which are easily to start as a PUK and confused as a PUK and given steroids. So there is no role of corticosteroids in Pythium keratitis.
Correct. That is the answer that I was hoping for from you, because people see anything peripheral, they assume it is immune. Even if they see an infection, they probably believe there's an immune component and start the steroid. So my answer would be the same as yours, where if I remotely believe it is Pythium, I will withhold steroid therapy. Thank you so much, Bhupesh. Dr. Rajshekhar, do we have any questions from the PGs for the panelists? Dr. Mohan Rajan?
Yes, Radhika. Two questions. One on BCL. I think Meena has touched upon it. The other question is mixed ulcers. When a fungal turns mixed, the panels opinion on it. I think he's an young ophthalmologist.
That's a very good question. Mona, would you like to take that? Dr. Mona Bhargava? Dr. Mona Bhargava has got the, a special capacity that she's dealt with these infections both from southern India as well as northern India. So she has the best ringside view of the geographic distribution of fungal keratitis. So here we have a young student who's asked us how we deal with mixed infections or a secondary bacterial infection over a fungal infection. So would you like to take that question, Mona?
Yes, ma'am. Thank you, ma'am. In northern India, usually we see that, north and this part, eastern India, we see that Aspergillus is more common. Whereas in southern India, Fusarium is more common. So depending on the organism that we get, accordingly, we have to target the therapy. And as Dr. Meena has rightly elaborated that for Fusarium, netamycin is the drug of choice in all, as the first line of therapy. And for Aspergillus, we can either start amphotericin or, netamycin would not be the first line of therapy, either ampho or voriconazole.
Now, how about mixed infection? Suppose there is a bacterial super infection. What would help in the diagnosis? First of all, how do we get to know that there is a bacterial infection, and how would we modify our treatment of the fungal keratitis?
Yes, ma'am. For superadded infections, the only scraping can help for diagnosing these kind of infections. So if we get a mixed infection on scraping, like a bacterial plus fungus, depending on which bacteria we are getting and which part of, as we do have increase in antimicrobial resistance patterns in the northern and the southern part of India. And we see that the Pseudomonas is becoming resistant to fluoroquinolones in all parts, moreover in northern India. So depending on whatever organism we are getting, if we can get through the culture and sensitivity, then accordingly we can start. Otherwise, if it's not responding, Pseudomonas is not responding to fluoroquinolones or aminoglycosides, then we might have to switch to other forms which have been elaborated in your talk, madam.
Thank you so much. Thank you so much, Mona. And as an extension of that, I will add one practical point that I have seen in my practice is that quite often the bacterial contamination happens because of contamination of the eye drops of the patient. Quite often we see a situation where you start with a small fungal ulcer, you feel that with say monotherapy with natamycin, this is going to heal, and then it starts healing also. Then it comes to a plateau. Then you're a little bit worried, not very worried, but you're a little bit worried. Then after a few days, what started as a 4 millimeter ulcer suddenly becomes a 5 or a 6 millimeter ulcer. And then you see that the hypobion floods half the anterior chamber. So now you're flummoxed because this is not what you started off and this is not the course that you anticipated. Quite often, if you go back and check, these are the patients who started off with steroids from elsewhere before, and these are the patients who've been careless with their eye drops because these are all reconstituted medication. So who've been careless with the eye drops, they've extended the use more than 3 or 4 days, or they're not capping the bottles properly. And the secondary contamination comes from the eye drop. So along with re-scraping, taking a sample from the eye drop or changing the drop and the container and instilling some hygienic practices in the patient can circumvent or reduce this problem to some extent. Anybody else has anything else to add? Yes, sir, please.
Now, why there is a difference between the organism in South and North India and East India? What is the reason for that?
Anybody wants to answer that $1 million question?
Probably environmental, doctor. It's just environmental.
I think it's just the genetic makeup of the organism, just like individuals genetically differ from place to place. So the environment dictates a bit of, how the organism develops as well.
You
so
see that bacterial ulcers? You don't see that in bacteria. You see only in fungal. No?
Yeah.
That's why
even in bacterial ulcers, sir, the Madurai group has published that they see more Streptococcus pneumoniae than other places, and also they have proved that the nocardia has significantly increased. So no other group has actually published this data of increasing incidence of nocardia and Streptococcus pneumoniae. So keep in mind that this is what is called emerging infections. So some infection which was not present earlier is now coming back or increasing in incidence. So to answer the question of the polymicrobial keratitis, many of these are diphthyrioids also, which are actually commensals. So diphtherioids, you have to see the virulence of the organisms once you have a polymicrobial keratitis. So predominantly it will be the fungal keratitis which will be the culprit. And if you see something which is virulent like Pseudomonas, then you treat the patient more vigorously. But if you see diphtherioids and things, these could be just be the commensals. There's a rise in diphtherioids now in our part of the world.
Another form of mixed infection is acanthamoeba with fungus.
Yes, ma'am. Your group has
Yes,
very
we have seen
nicely
many,
published.
and that also we have to keep in mind when the response is not as we expected. Look for other organisms like acanthamoeba.
And you have found demetaceous fungus also with acanthamoeba.
Yes.
That's very rare, ma'am, actually.
Also, I think Shweta from our hospital has published that the microsporidial spores also can mimic fungal infection. So it's going on being treated as fungal infection, seeing the spores, but the spores actually were a little bigger spores of the microsporidia, for which there is no medical treatment, and finally the therapeutic PK button revealed. So it sometimes can look like something while it is, not actually that. So we should not doggedly follow a single course. We must be willing to change the game plan depending on how the clinical situation evolves. So thanks, Meena, for those very nice points. Any other questions, Dr. Rajshekhar, from the listeners?
The other points they have touched upon, so we'll go to the next talk, Radhika.
Fine. In that case, we come to the last and probably a wonderful talk in this session. I invite Dr. Mamta Agarwal, my colleague, who as I already mentioned, straddles two specialties. So she is the ideal person to deliver a talk on peripheral ulcerative keratitis. And the collection of patient details and photos that she has is simply fantastic. So I never tire listening to her talks, and I'm sure you'll join me in appreciating the same way once she concludes. So over to you, Mamta.
Welcome, Mamta. Pleasure to have you on board. Muted. Mamta is muted.
1 second, sir. Yeah. It's okay, sir, now?
Yeah, it's fine.
Hello, good evening, all. Thank you so much for wonderful talks and a wonderful program. And I know it's fag end of the day and the weekend, but I hope we can still discuss keratitis further and make our Saturday evening more pleasant. So a lot of infections we've all talked about. Now I'll be talking for the next few minutes about peripheral ulcerative keratitis, one of my favorite fields in inflammation. Starting with this case, this is just a 45-year-old patient who came to me with decreased vision, pain, and redness for the last 3 months in his right eye. Known case of diabetes, visual acuity, as we know, he was just counting fingers close to face. Investigated in detail, and we found C-ANCA positive, and HRCT lung also showed pulmonary nodule with a ground glass opacity in the left upper and lower lobes. So looks that the diagnosis was quite simple. It was a patient with granulomatosis with polyangiitis. We discuss in more details in the next slides. So what is peripheral ulcerative keratitis? It's just a destructive inflammatory disease of the juxtalimbal corneal stroma. What do we see? It's an epithelial defect. There are stromal inflammatory cells. Progressive stromal melt in a crescentric form. Adjacent structures like conjunctiva, episclera, and sclera get involved. It may lead to corneal perforation, scarring, thinning, and vascularization. And what are the etiology for the same? It's like infections or non-infections, being it ocular or systemic. But what is the exact pathology? We're still not knowing it. So what they say is that there has to be an inflammatory stimulus. It can be a microbe, it can be an immune-mediated disease, malignancy, trauma, and more, which are still unknown. And what it causes is neutrophil recruitment, activation of complement pathway in the tissues and blood vessels, which increases the vascular permeability and brings more chemotactic factors, and thus bringing more neutrophils, which they release collagenolithic enzymes and proteolytic enzymes. Hence, the corneal stroma becomes necrotic and there is progressive thinning. And this is what we all know is peripheral keratitis. I'm sure there's much more to it. This is just a simplified explanation, what we've been reading from years now. This is just a chart to show that what are the conditions we should think about when we see a patient with peripheral ulcerative keratitis. These are ocular conditions, or it can be associated with systemic diseases. Ocular conditions, as we discussed, bacterial, viral, acanthamoeba, fungal. It can be a diagnosis of exclusion in a patient with Moran's ulcer and few others here. But the systemic diseases besides the infections, we can see as rheumatoid arthritis, SLE, Wegener's, polyarthritis nodosa, and few others. So here to just show a pictorial thing, like this is a patient with rheumatoid arthritis, and we see there's a 360-degree peripheral infiltrate. And another patient, right and left eye, what we are seeing, a white ring, so subtle that we can actually miss it in the clinic. But this is a patient with SLE, and he has this infiltrate with a scleral inflammation in both eyes. So what about simply ocular diseases? Have a look in this one. This is just a patient with Moran's ulcer, 360-degree peripheral melt. And another patient with a Mycobacterium tuberculosis. This we published in one of our OII journal. And this was a multi-drug resistant tuberculosis. And this is a patient with herpetic keratitis. If you look at 360-degree, the whole cornea is getting involved. And we really have to look with different illumination on the slit lamp to know what is the actually seriousness of the whole cornea which is involved. How do we evaluate it? So symptoms, the patient can be 6/6 or just a light perception. He may have pain, redness, watering, and photophobia, but the decreased vision can be because of astigmatism or corneal opacity, or it can just be a perforated cornea. And what are the signs? As we see now, the first patient, what I showed, it's a peripheral crescentric ulceration, as we see here, intense inflammation of the sclera and limbus, and there can be anterior uveitis, inflammation in the anterior segment, cataract, and peripheral thinning with vascularization. So this is another patient. What we see, he has inferiorly, when we see a crescent infiltrate, there is corneal thinning, and superiorly we had to put the glue to just tide over the acute inflammation. Patient can present with these gray white infiltrates. The peripheral cornea can have an epithelial defect, superior stromal thinning. It can spread circumferentially with an overhanging edge or an undermining leading edge, as we see here. So this is what we mean that this is an overhanging edge. We see that there is scleral and corneal thinning. Here it's already perforated. We see the uveal tissue, but this is another, what we call is an overhanging edge. And this is a patient with Moran's. So you can see the patient not just in acute stage, but also in this kind of a chronic phase. Some parts are healing and some parts are still active. But we see again an overhanging edge here. Over a period of time, the peripheral cornea is becoming a papery thin cornea, what we all see. There's no defect here, but then there are vessels. And this is a patient which is referred, patient underwent conj resection elsewhere, and this is just a central island of cornea. The disease is still progressive. And this, in extreme case where we don't know what's happening, but it's just perforated. And again, the whole peripheral cornea involving the center now is inflamed. And we can also see not just acute stages, we can see these patients in the healed stages. When we see a picture on the right, there is scleritis. But what are these white spots on the cornea? These are healed PUK. Because these are immune-related diseases, a milder form can self-heal. And we see these marks or the footprints of earlier PUK. And PUK, what we call, it may be associated with these things, scleritis, uveitis, and cataract. This is one of my patient, bilateral PUK with scleral inflammation. Once the eye was quiet, this is phaco we could do, and light perception changed to 6/12. But here, because it was a hypotenuse globe, we had to just do a lensectomy and vitrectomy, but the visual acuity improves to 660. So coming to the systemic history, it's very important that we know all the systemic examination in these patients, which involves skin, respiratory diseases, genitourinary tracts, musculoskeletal history, then again, neurological, eye, nose, ear, mouth, everything. We have to really be in detail examination to rule out the diseases like Wegener's, SLE, polyarthritis nodosa, and few others. So this is a patient collection, just a patient with rheumatoid arthritis. We have to really look for these swan neck deformities and joint deformities. And this is an interesting patient who had this swollen pinna, and she presented with a nodular scleritis and few lesions on the cornea. And this is my patient who's presented with bilateral corneal lesion, and he had this spot on his nose, and this was due to SLE. And patients can be HZO or patients can be having infectious diseases like Hansen's disease. So what do we investigate now? It needs a complete investigation, including a complete blood count, liver enzymes, renal function test, syphilis to rule out RPR and TPHA, and then to rule out tuberculosis, we do MAN2, HRCT chest X-ray, and the immunological workup, which needs RA, ANA, anti-CCP, ANCA, and serum ACE, a complete urine analysis. And if we are suspecting an infection, we need to do a microbiological workup for smear culture and PCR, which has been really discussed and well detailed. Few other investigations, if we do not see the fundus, ultrasound needs to be done. Fluorescein angiography and ASOCT also helpful in few cases. What is the goal of treatment? To promote epithelialization, improves the surface wetting, especially in patients with rheumatoid arthritis, where keratoconjunctivitis sicca is one of the main things which bothers us. And we have to suppress the immune-mediated inflammation and then further prevent complications. So what are the topicals we have? We have lubricants, which has to be preservative-free. It increases surface wetting and it dilutes the inflammatory mediators. We also use collagenase inhibitors like 20% N-acetylcysteine, which prevents the further melt. Then steroids, immunosuppressives are main goals, which we have to achieve to control the inflammation. Cycloplegics, just to reduce the ciliary spasm in case we have anterior uveitis, and antibiotics in case of infections. The systemic management is the main therapy actually in these patients. Antibiotics for tuberculosis, syphilis, herpes, just in case these are infectious. Oral tetracyclines, which are systemic collagenase inhibitors. Oral and intravenous corticosteroids, to the extent that we can give intravenous methylprednisolone to control the acute inflammation. And then steroid-sparing immunomodulators, which includes methotrexate, azathioprine, mycophenolate mofetil, cyclophosphamide. And latest, we have biologics where we have infliximab, adalimumab, JAK inhibitors, TNF blockers. We have also rituximab, which is CD20 blocker. And we have tocilizumab, which is a IL-6 inhibitor. So now discussing the case, this was a patient we showed earlier, and this is pre-treatment, and here this is post-treatment. 2 years, and now he's on oral pred, azathioprine, hydroxychloroquine, and also cyclosporin 8%, so that he doesn't get the side effects with topical steroids, and he's maintaining well. And this was one of my patients, 59-year-old patient, history of psoriasis and gout. He was all collagen workup negative, but CRP was high and ESR was high. So this is pre and post-treatment, right eye and the left eye. Complete inflammation, the whole thing is resolved. The patient is maintaining well. How about surgical management? If they're impending perforation, we know less than 3 millimeters, we can apply cyanoacrylic glue and bandage contact lens. 3 to 5 millimeters, what is the ideal thing we know? It's a Tnoa patch graft. We also have amniotic membrane transplant. And worst case, we can use corneal patch grafts. But conjunctival resection in mild cases in Murren's ulcer have also been described, and lamellar and penetrating keratoplasty in extreme cases. So this was a patient I showed you earlier. I had to do a glue BCL for him, and patient was treated with oral steroid, IV rituximab, and also these topicals. This was a patient, this was a post-conjunctival resection, but now the patient on systemic immunosuppression. This was one of my patients where I did a patch graft, and patient has to be on immunosuppression for a long time. So in conclusion, I would say that PUK inflammatory disease, we have to do a complete workup, ocular as well as for systemic disease, rule out the infections, and then we are safe to start the systemic medication. Identify the causative factor, suppress the inflammation, and hence prevent all the complications. Thank you so much for patient hearing.
Thanks a lot, Mamta. So that was, as usual, a fantastic array of very interesting cases from one end of the spectrum to the other. So my question for you is from among the last slides in your presentation, that biologicals and immune modulators have, altered immunological disease treatment, by a wide margin. And ophthalmology or corneal disease is only one very tiny part of that, entire game. So when and how would you introduce biologics in the treatment of immune keratitis? Because on one hand, The way I understand that their action is much more instantaneous as compared to immunosuppressants. But on the other hand, these are very expensive medication to use. We don't know the potency and side effects. We need to involve an internist, and worse still, in our country, flare-up of tuberculosis can be a problem. So at what stage and how would you employ these medications? Because I did see that one of your patients got better on rituximab therapy.
So thank you. That's a really interesting question and a very valid point for practical issues. So you usually divide these cases into one which is acute and chronic, and two it is mild, moderate, severe. Severe diseases like Wegener's, it doesn't give you time to think. So we have to be really very, very rapid in these cases. And in that stage, acute stage, we have two things: IVMP, intravenous methylprednisolone, and intravenous cyclophosphamide, which are like clear shotguns, act immediately. And also we have rituxan, which my patient was used. So it depends upon the rheumatologist, because they examine the patient systemically and they can take a call. If it's only ocular, I prefer to give cyclophosphamide and IVMP initially, because we know the results and we have had good experience. And two, it is cheap. It doesn't cost too much for the patient. And on a long term, Wegener's, now I see a lot of patients are on maintenance doses. It's like every few months they give, and it's a beautiful resolution and has less side effects as compared to other biologics. Infliximab, now it's like an old one. We have an experience of 10 years and odd, which is one, very expensive, and two, it is like makes the patient very dependent. And for Indians, it's very difficult to control the amount of money it takes into. So that is really going out of sight now, because the only thing which we know very good results is adalimumab, Humira, but again, that takes long time to act. It doesn't act immediately. For the acute part, we have only these three: rituxan, cyclophosphamide, intravenous methylprednisolone. And again, when we have to put these patients on immunomodulators, there's no second thought to it. All these patients with systemic diseases and even murals, they have to be put on oral steroids for the first few months till the other medicine kick in. And the other medicines can be a milder version from methotrexate, azathioprine, or the biologics. So we also have now this one, JAK inhibitors, which is again coming into picture, and people are having more and more experience. But I would still add that it has to be used with really cautionary dose. Why? Because we are seeing activation of herpes with JAK inhibitors. I've had 3 patients now. Patients were started for scleritis and JAK, this one, tofacitinib, and bilateral herpes. She's a doctor, comes from Pune. So you have to be very, very careful about the side effects with all these biologics. They act very fast, but it's not something that we can just simply use it. Tuberculosis is another big issue in Indian population. So you really have to be very cautious to keep them on, because most of the time patients don't turn back. They just pop up the pills and they think it's like paracetamol. So we really have to have good follow-up whenever we are using any immunosuppression. And then we have to monitor these LFTs and RFTs also very, very careful.
Right, that is very well said, because these are all double-edged swords, and we need to use them not only with caution, also in collusion with the internist or the person who's better versed in using these medications than we ourselves. Which sets the tone for my next question to Dr. Somshila Murthy, who also belongs to the same world as Dr. Mamta, in which she straddles both specialties of, corneal infective as well as inflammatory disease. So all these treatments that Mamta has postulated, Somshila, how would you, put them in perspective in an order? I have often seen and been awed about the step ladder approach that you described to managing peripheral ulcerative keratitis. So could you say it in a capsule or, condensed form for our listeners?
Thank you, Radhika. Enjoying all the talks, and Mamta really enjoyed your very lucid presentation on PUK. I think Mamta has already pretty much covered most of the points. And for the residents, what is more important is, as was highlighted, that in Mamta's presentation with her pictures, that to recognize the various causes of peripheral ulcerative keratitis and to differentiate whether it's infective or immune mediated. So your step one, the step ladder, So basically, the step one in the step ladder approach. Am I audible now?
Yes. Yes.
Or should I be better than this?
That's better. That's okay.
Okay. So the step one in the step ladder approach is to differentiate between the infective versus the immune mediated PUK. Already Bhupesh had highlighted that there can be some infective causes such as a peripheral fungal kind of an ulcer, or HSP, herpes, can often start as marginal keratitis, and pythium, which is of course very rare. So I don't think the residents need to be that sort of apprehensive about it, but certainly the commoner ones can initially start as a peripheral ulcerative lesion. So we should be very cognizant that it can start as an infective kind of a cause. Once you're very sure that it's immune mediated, then the algorithm is a little bit complex to be given in a nutshell, but I think it's covered by Mamta that we do start on oral immunosuppressants such as steroids and immunomodulators, as she has mentioned. And based on the severity and the systemic association, which can be some grave diseases such as rheumatoid arthritis or granulomatosis polyangiitis and SLE, which is by itself a rare disease. So based on the systemic co-associations, we have to ramp up or step up the immunosuppression. So in a nutshell, rule out infective. If it's immune mediated purely, try to figure out what is the systemic association. If there is none, then you might go with oral steroids and immunomodulators. If there is systemic association, collaborate with the rheumatologist and go on to more aggressive therapy.
Right, and like Mamta said, you also believe in using biologics only for people with systemic diseases, whereas when you can't find a cause laboratory-wise, you would stick to immunosuppressant and steroid. Is there even a divide like that?
Extremely rare case, well, not extremely rare, but probably the cases that come to the tertiary centers. Maybe Mamta and I, we might see these very difficult recalcitrant cases where everything has been investigated several times systemically and everything is negative. So in these cases, even the fifth level, I would say, like biologicals and so on, may have to be used, keeping in mind the cost and other side effects, including infection, as mentioned by Mamta.
Right.
So I would add here that we cannot divide it as ocular and systemic needs biologics. No, that's not the message I would like to give. Yeah, if it is, it can be. Nowadays we see a lot of things which we call ocular vaginal. So if the globe is layered perforation, let's say the 360-degree necrotizing scleritis with the keratitis, that is an indication for the most acute. Yeah, that has to be IV cyclophosphamide. So that doesn't need that we need to have a foci in the lung or a kidney that we have to go. So we can actually tell the rheumatologist that I need an acute injection for IV cyclophosphamide. That's all. So it doesn't need a systemic foci for us to be so aggressive in treatment. Definitely, cornea is perforating. We need scleritis. We can definitely go ahead with cyclophosphamide, which the action is really prompt.
Right. And like both of you mentioned, and to quote Bhupesh also earlier, that one of the differential diagnoses for peripheral ulcerative keratitis was also infective peripheral ulcerative keratitis. It's very uncommon, but it can be there. You have herpetic blepharoconjunctivitis and you have pythium, which can produce a gutter. But then I recall that Mona had once discussed with us in our department class about a rare masquerade of OSSN looking like peripheral ulcerative keratitis. Did you not, Mona? So could you just briefly recall the points in that case so that people can be mentally prepared if they see something like that?
Yes, sure, ma'am. Thank you, ma'am. Actually, as we have seen in the Mamta's talk, that PUK can be a harbinger of alarming systemic diseases, like she has already elaborated. So one needs to keep in mind and rule out ocular surface neoplasia in these kind of cases where there is absent of discrete conjunctival mass, and we just see localized ulceration or necrosis of the conjunctiva and sclera along with the inflammation of the conjunctiva, thickening of the conjunctiva, or there is presence of blood vessels or a feeder vessels kind of thing there along with the keratinization. So in all these cases, if there is any doubt, then impression cytology should be done in these cases. And one should look out for inflammation of the entire ocular surface or increased inflammation of the anterior chamber or presence of sudden corneal perforation without any cause. Or in these kind of cases, always should be investigated because of the presence of alarming anterior segment inflammation or increased intraocular pressure without any cause. And the other important factor is the nodulo-ulcerative variant of OSSN can actually mimic scleritis, sclerokeratitis, and this should always be ruled out. If we see cases where there is scleritis or a sclerokeratitis which is not healing, it can be a mimicker. Few other important take-home messages would be that corneal Delin in these cases should always be taken proper care of, because whenever there is a perilimbal elevated mass, it will result in a Delin formation in the cornea. And whenever there is a Delin formation, it can lead to a microbial keratitis. And if that is not taken care, it can result in perforation, and that can even result in metastasis or the spread of the intraocular tumor, which is just which was just earlier present on the surface because of the recurrent inflammation and the perforation that has happened. So these things should be taken care of. And malignancy should always be kept high on the list whenever there is a non-healing ulcer or any chronic inflammation, which is not subsiding even with the use of steroid drops. And the other important factor is also to always remember the mucoepidermoid component of the tumor, because that results in metastasis, earlier metastasis, as well as non-healing ulcers, or which it is known to cause recurrences very often. So that should also be taken care, and special stain should be done in these cases, like mucicarmine stains, colloidal iron stain. These should be done so that the mucin can be identified easily and earlier to diagnose this, because sometimes it can only be identified in the recurrent squamous cell carcinoma. In the first go, it cannot be identified until unless we are very suspicious and use these special stains in these cases.
So anything that doesn't go away, you need to exercise a little caution to kind of ensure that we probably are not on the right track. And any tissue that is taken out of the eye in these patients has to be subject to all possible tests, histopathological and methodological, instead of having a single track mentality. My last question is to maybe Sumti and Preeti. Both of you come from cataract surgery intensive institutes. So what do you do when you want to do intraocular surgery for these patients with a background of autoimmune eye disease? You take them up immediately, or you cover them with anti-inflammatory or a steroid cover before taking up for surgery? How would you approach a healed murens in the context of cataract surgery? Preeti or Sumti, whoever wants to answer? The young gurus of the lot.
Actually, in PUK cases, like we try to kind of control the inflammation first, and then once the eye is quiet, then probably think of cataract surgery. Because like when inflammation is not under control, you go in and touch the cataract, then definitely it is a losing the eye. So first control the inflammation and then plan the cataract surgery.
Yeah, please go ahead.
Yes, ma'am. You had some question.
Yeah, so would you cover the period of cataract surgery also with immunosuppression was my question. So somebody comes with a healed murens, if given the quiescent period of 4 months or 6 months, and then at the time of surgery, because you're provoking another inflammation with your surgical insult, would you cover up the perioperative time with any form of immunosuppression?
Yes, ma'am. Even if a patient has a proven case of either autoimmune or even a HSV keratitis, we give a cover of at least a minimum 1 week cover of the oral medications, and then during the healing period as well as in the post-op also we cover up with the medication.
And Preeti, have you tried using topical cyclosporin, your favorite medication, in these situations? If Preeti is not around, then you can tell us also something.
Ma'am, topical cyclosporin, in which I didn't get your question.
For the same purpose of immunosuppression.
Ma'am, I don't have much experience, but definitely yes, in one case of HSV keratitis, like I usually put her on oral, she's on oral antiviral as well as topical steroids. The moment I stopped on topical steroids, she will come back with in a week or 2 weeks time recurrence. So now I kind of give her a topical steroid, and when I was tapering, I started including a cycloimmune eye drop. And then now actually with the oral antiviral and with the cyclosporin eye drop, she didn't had any recurrence actually.
Okay. Dr. Rajshekhar, over to you. Any other? I think we're well past the time. I could go on all night like this, but I'm not very sure that everybody will be on the same page. So is there anything else that we need to address or answer? Questions?
Yeah, Radhika, 2 or 3 points, but all have been touched upon. One, I think the final take home is one comment which one person has said. He said like this: I think your panel will want to discuss that. How long will it take for all steroids to be stopped and only rely on biologicals and immunotherapies?
Mamta,
How
you
far
want
in
to
the
answer
future?
that question?
Can
He's
I just
asking like a comment. How far
Yeah.
in the future will we not use steroids and only rely on biologicals?
No. That's like steroids cannot go off the shelf. Steroids are like the treatment for any inflammation, be it ocular or systemic. And because they act spontaneously, when we have an inflamed eye, we need a drug which acts immediately. And the biologics, we have very few which act immediately. Like we have now JAK inhibitors, which can take care within a week or two, or we have rituximab, which can take, but otherwise, cyclophosphamide and steroids cannot go off the shelf. They are the drugs for, but we should know how to manage with these drugs. We cannot go endlessly with these drugs because they can take care of the disease in the first 2 months. Cyclophosphamide has its own side effects, which are really very serious. Like it brings down your immune system immediately because these are cytotoxic drugs and these have malignancies. So patients have to be very, very cautious. So what we give is pulse cyclophosphamide, which takes care of the acute phase. And then we switch to the drugs which we can give safely over a few periods. So there is always a pattern here. So I would not suggest, like, since we are discussing more with the residents and these things, for the patients who are in, we see in tertiary care, it's a different ball game altogether. And people who are not well versed with biologics, with other medicines, steroids is still handy in the acute phase, but then they should be referred to the higher centers, or they have to be taken care by the immunologists, rheumatologists who know how to, but we have to guide them. It's not very simple that some people who have no experience and they can guide, because rheumatologists, they ask us actually, how do you want to gauge your treatment? Because not every patient will have a systemic disease. So these drugs really need a lot of experience with that. It's easy to just say that we can give this and this and this. But when a patient comes practically, there are a lot more to it, actually. There are so many side effects. We have to be really cautious about the hypertension, the blood counts, about the tuberculosis, and cardiac illnesses. So patients, they can come with comorbidities. So the steroids are the easiest one, so that at the primary level, tertiary level, people can take care. So it cannot go off the shelf, definitely.
Like Mamta very rightly said,
True.
it is very difficult sometimes to convince the rheumatologists, because many times these people don't have systemic problems. The ones with systemic problems are very less. It is like somebody is telling us to give eye drops to a patient when they don't have eye disease. So like that, the rheumatologist is unwilling to give life-threatening medication to somebody who he does not examine to have a body problem. So it is very important to establish an equation where they know our patient profile and what we are talking about, to arrive at a treatment.
And not every rheumatologist can say, people can say, patients, they say, I can see my rheumatologist and take it. No, I have a strict no to it. They have to see our rheumatologists who know how do we deal.
They need
and
to
it doesn't
understand
work
our
like
perspective of the disease. And to the person who asked the question about taking the steroid off and introducing only biologics, steroid is like main course and biologic is like dessert. Each has got its place in the table and is not interchangeable.
It's not interchangeable.
Anyway, let me compliment Mamta. Wonderful talk, Mamta. Really,
thank you so much, sir.
360-degree coverage. And as you rightly said, no, rheumatologists are very, very conservative. And just like pulmonologists, if you send a patient saying that, no, this patient requires anti-tuberculosis, they will say, no, there is no evidence of tuberculosis. I will give anti-tuberculosis.
These two things, ophthalmologists have to be really well versed, and we should be very confident that we need it. That's about it.
Absolutely.
So there is no to it. If we need an ocular vaginus, we are seeing, and we need a rituxan, then our rheumatologist will start it.
Probably you need an ocular rheumatologist.
That's why we have common rheumatologists whom we keep sending, so that they get convinced about the patients and ocular diseases, because for them, ocular diseases are minuscule in the amount of systemic diseases they see.
Yeah, true. Yammar sir, I think closing remarks. We have already almost touching 10.
It's really, we didn't know the time at all. We're all glued to the edge of the seat.
Yeah.
It was so interesting because all the speakers were fantastic. All the panelists were even better. And I know the discussion was very good. The moderation by both Dr. Radhika and Dr. Rajshekar, really, truly incredible stuff, I would say. And the way they created an atmosphere of learning is really fantastic. Thanks to Radhika and the entire team of Shankar Nethralaya for organizing this wonderful ARC masterclass, probably one of the best. Last week, we had one masterclass on uveitis, wherein JB really got, it was actually an international masterclass. If you looked at it, it was really wonderful. But this was even better than that, I would say. And hats off to the entire team here. Lots of learning, new things, new concepts, lots of learning and how to deal with this, when to refer, when not to refer, how to take care. And I think every aspect has been covered. I am sure it will be very, very useful. And this will be preserved for posterity. This recording from the Milmet, I'm sure it will be done. And we're very thankful to Milmet for organizing and sponsoring and powering this ARC masterclass, which has been truly a remarkable success, I would say. Truly a remarkable success. One of the best programs of the TNOA this year. And I'm sure it will be continued next year as well under Dr. Ramakrishnan. Dr. Rajshekhar, over to you, yes, because you are the chairman, you are the pivot, I would say, as far as the TNOA ARC masterclass is concerned. Yeah.
It had been a wonderful 2.5 hours, and I think a lot of things have been so very lucidly told by the expert team. I believe a lot of our residents tomorrow will be starting cyclo, and we will also see a lot of our residents trying to be very meticulous in their scraping. And these take-home points, I think, surely will stick on for a long period of time. And the effort of these teachers surely will last in the minds of the residents for a period. I should thank from the bottom of my heart and from ARC and from TNOA, Dr. Radhika, for giving us such a wonderful, veritable feast. Radhika, your words, final words.
Thank you really so very much. You both took the words from me. I should sincerely thank, Dr. Mohan Rajan and TNOA, for the opportunity and the platform. Like I've told him, this is a subject and specialty which is very close to my heart, and I can never get tired of talking about this or listening to it ever, as Dr. MR sir knows, and he's given a nice platform for it. And the co-moderation done by you brought forth the questions of the PGs so that their queries could be answered. My very sincere thanks to my colleagues from Shankar Nethralaya who shared their expertise over here. And bigger thanks to faculty from other institutions like Dr. Repti ma'am, Dr. Bhupesh and Dr. Somshila, who after a long day's work have shared their time and expertise over here. And to the little ones, Preeti and Sumti, they're still little for me, even though they're big consultants in their own right. It's been a pleasure interacting with you on an academic platform at a tutorial level. So thank you so very much. It's been a pleasure putting this together, and I hope all of you enjoyed it as much as I enjoyed putting the program together. Thank you very much.
And important take-home message, I think Radhika requires a one full-day masterclass. From morning 8 a.m. night 8 p.m. There will be a masterclass, and she can go on forever.
Thank you so much, sir. I choose to take that as a compliment. Thank you so much.
And I am sure it will spill over to 10 o'clock in the night. Thanks a lot. Thanks a lot for everyone.
Yeah. Thank you. Thank you so much.
Thank you. Thank you. Himanshu, we can sign out. Thanks a lot.
Thanks a lot, Himanshu. Raju, Ketaki of Milmet. Thank you. Meena.
Thank you.
Rajshekhar.
Yes, sir. Thanks, sir. Wonderful session.
We'll see you for the MICS TNOA Connect series.
Yeah. Yes.
Bye.
Bye.
So with your permission, close this meeting.
Yeah, please.
Thank you.
Yes.
Thank you. Thank you very much. Thank you. So from here, I'm ending this meeting. Thank you.